thanks to everyone for joining us today for the 15th convening of the Low Value Care Task Force. We have a couple of slides of housekeeping to go over. We ask that you please add your affiliation to your Zoom name. Simply click Participants at the bottom of your screen, hover over your name, and click on the More drop-down button. Then rename and include your first and last name, followed by your affiliation, please. We'd also like this meeting to be as interactive as possible. When you'd like to ask a question or make a comment, please raise your hand. You can usually find that under the reactions button at the bottom of your screen. If you don't see reactions, then click on More, and you should find reactions in the pop-up menu there. When it's your turn to speak, please remember to unmute yourself and turn on your camera. After speaking, please lower your hand, mute yourself again, and go off camera. And now, I'm going to hand things over to Mark Fendrick.
Thank you so much, Susan. Can you hear me okay?
Yes.
Yes.
Thank you. I can't believe this is the 15th convening. I'm super excited to get started. We have such a full agenda that Cliff Goodman will take you through in a minute. I just wanted to express Mike Chernew and my thanks to all of you. The fact that we've been doing this for the 15th time shows something about the issue. It's pretty hard for Mike and I to believe that it's almost 25 years since we started a research and policy agenda to remove financial obstacles to essential clinical services. And it's even more strange to think that the VBIT Center is now in its 20th year that Mike and I founded when he was here at the University of Michigan. But soon after folks started implementing programs to reduce cost sharing on high value services, we realized that in the short term, at least, when people bought more things, they actually had to spend more money on healthcare. And it was Mike and Gail Walensky and several of the VBIT Center advisory board members who basically said, we have to find out ways to pay for more people getting preventive care, getting chronic disease medications, high value procedures, et cetera. And we didn't like the idea of raising premiums, which is what was going on. And even more so, we really didn't like raising deductibles and cost sharing on all services, which we called a tax on the sick. So thus we were forced, at least I was, Mike remembers how chagrined I was, to become a low value care guy. And we published in Health Affairs a paper in 2010, talked about how you could use value-based insurance design and other methodologies to reduce care that we shouldn't buy even if it's free. Luckily, 6 months after that, we got a gift from the heavens, if you believe in such thing, in the creation of the Choosing Wisely program at the American Board of Internal Medicine Foundation, which we'll hear a bit about that and where we're going afterwards. And then, of course, in 2017, we were really pleased to see financial support, as well as even more so constituent support from a broad range of people who pay for healthcare and other key stakeholders to get involved in this movement to identify, measure, and reduce low value care. Next slide, Jordan, please. So there are people like, younger folks like David Kim and John Maffei on the call who've kind of benefited from the excitement, at least in the peer review literature on low value care. The two of them and several other people who've spoken to the Low Value Care Task Force has contributed mightily to this list of low value care publications, as well as many of our members who are non-academics who are working in this space, like Beth Bortz, who would probably get tenure here at the University of Michigan, not sure about Harvard, but given all her contributions to this space, and Beth Boden-Seiler and so many other folks who are in this place. But I think that one of the themes of today's meeting, and I'll turn it over to you, Cliff, in a minute, is Mike Chernew said at the VBIT Summit that we've been trying to reduce low value care for a very, very long time. And sadly, with rare exception, most of the evidence suggests that we're not doing a bang up job, even though we have some successes, which you'll hear about today. So Mike said during the summit that if we can't reduce it, we should probably stop just paying for it. And I'm hopeful that as we go through today's agenda, that we'll hear some impressions from you, the members, on this approach about potentially engaging key stakeholders to put more pressure and accountability on providers who are largely responsible, at least in my opinion, for the provision of these billions of dollars in low-value care services. So I'm very excited about today. Next slide, please. This wouldn't happen, of course, if it wasn't for our sponsor of today's meeting, Johnson & Johnson. Thank you, Silas Martin. I see you're on board for you and your team, not only for supporting us, but for your excellent work that you're doing in this space. Next slide, please. And importantly, thanks to Silas and his team and hopefully some other organizations, we have locked in the date for number 16 of the Low Value Care Task Force. Please put October 1 on your calendars, same time, 12 to 4. It will be virtual as always, because that has been the strong preference from our members. And I'm just very excited for today's conversation and know that we'll be continuing it, since many of you know I'm in touch with you in the interim between meetings between now and October 1st. Next slide, please. So with that, it is my great pleasure and privilege to turn over the moderation of today's meeting, as he's done for all the meetings prior to this, Cliff Goodman, our close friend and colleague. And with that, Cliff, I'll turn it over to you.
Thank you very much, Mark. And I have been pleased and privileged to be able to moderate these wonderful task force meetings. I will augment something that Mark said with regard to where we are insofar as progress. We are going to hear some real winners here along the way, and I'll mention those in our agenda insofar as some wonderful successes. We'd like to see more of those, but in the meantime, the environment is fluid. Anyone who's watching or waiting with much thought and some trepidation, the Braidwood versus Becerra case, know that there's some high-level, national level goings on that may affect what we can do about low-value care as well as high-value care. So these are things to keep in mind along the way, both ends of that spectrum. Next slide, please. So here is our agenda. We're going to have some quick intros and member updates. I think there are 2 or 3 folks among us here that are new to this venue, and I'm going to ask them. I'm setting up Kim Jeanette and Mike Madalena, by the way, and perhaps others for that. Then we're going to move to Smarter Care Virginia, the preliminary results. And we're honored to have, as Mark said, the tip of the spear here with the folks out of Virginia, Beth Bortz, John Maffey, and Steve Horan. They're going to kind of take on triple roles there insofar as walking through what has worked and why along the way. Following that, we're going to move to another important angle here with regard to site of care. Carol Huffman, Austin Chang, Jeff Flynn are going to take a look at that from the standpoint of emblem and trying to help us understand what it is about shifting sites of care or preferential sites of care that can really accelerate and enhance our ability to address the issues of low value care. So we're very much looking forward to those. Now, at 1:30 Eastern, we're going to go to Josh Fangmeyer and Mike Chernow, Josh out of Minnesota, Mike out of Harvard and other places, to understand where we might, this is part of going next, and Mike and Mark referred to this earlier with regard to maybe we should stop paying. And so we're going to hear from Mike and Josh with regard to maybe we can go about this through the RFP process and being a little bit more explicit about when we're not going to pay. And so this is kind of trying to knock the door down a little bit with regard to making something happen, sort of a step function there, set it up in the RFP out of the gate. We'll take a 15-minute break after that, and then we're pleased and really honored to have Dan Wolfson here, and we'll have a little one-on-one fireside chat with regard to the Choosing Wisely experience. I want to hear Dan just at least briefly go over why the ABIM Foundation took on Choosing Wisely, what their experience was, what they accomplished, any lessons, and identifying any barriers or hurdles to proceed further on that. And Dan, I know, is not part of the ABIM Foundation anymore, but we want him to kind of take a 30,000-foot view from that wonderful and rich experience and try to shed some further light on this, especially because we're going to move to a section at 3:15 Eastern on priorities moving forward for the task force on low value care. This is an all-member discussion, so I'll be watching the raising hand function very, very carefully. And I would ask folks along the way in our agenda today, and anyone listening as well, to have at least in the back of your mind, where do we go next with this? Where are the best priorities? Are there some priorities past priorities that we should set aside and so forth. And so that will be important to keep in mind to kind of help set up that discussion. And then we'll close with me and Mike Chernow with regard to next steps and adjournment. So with that, I think what I'd like to do now is ask Kim Jeanette from UCSF. You're new to this. Can you tell us a little bit about where you are and what your connection is to this field?
Yes, thank you. Can you hear me?
Yes.
Wonderful. Thank you so much for inviting me. Mark actually invited me. I've been on the VBID board for quite a while. I was trying to figure that out over 10 years, I guess. And met with Mark last week because I was in Michigan for a meeting, and we were talking about the task force, and Mark extended an invitation. So thank you all for allowing me to attend. Some of you may know me from the Integrated Benefits Institute, where I was executive VP for a while, as well as research director. And right now I'm with the UCSF Institute for Health and Aging. And my main focus really is around good work. What does that look like? And, you know, what role does the health sector play in that, in addition to many other sectors? So I'm very excited to be here, and I will have to drop for the last hour. So a little plug would be to educate me a bit or help me understand if there are websites that already are tracking geographically where the low value pockets are throughout the country, and giving sort of continuous visibility to that. That would be my little input for the section of the agenda that I won't be able to attend. So thank you again, and I look forward to meeting all of you virtually.
Well, thanks very much, Kim. And by the way, for the part of the day that you'll be able to join, you can listen to some very good, it's better than case studies, really breakthroughs in how this has worked. There's some great lessons to be gained from that. And even after we break for the day, if you have any further insights you'd like to share with the group, we'll be able to do that readily. So really appreciate you being here, Kim. Let's move on. Mike Maddalena, tell people who you are, where you are, and how it is you find yourself joining us today.
Thanks, Cliff. I'm a consultant in mainly in the public sector world, where I've been working with plan sponsors for a number of years on a wide variety of issues, ranging from provider reimbursement systems to just how do we fund healthcare. I got interested in this topic a number of years ago. I've been fortunate to have known Mike Chernow for quite a while. Bumped into Mark a few times over the years on various assignments and projects. But basically, in that vein, trying to think about how we can affect low value care. I mean, it's been something we got very interested in a number of years ago with some of the original work. Aaron Schwartz work a million years ago or so on implementing measurements of low value care and claims data. Been using those for a number of years and brought them forward to more current versions, and always looking to refine that process. But just how do we, for the longest time, think about how do we avoid it, which to Mark, in your comments, Cliff, very hard to avoid. Maybe the answer is not to pay for it. So looking to incorporate some of those methods into reimbursement systems, et cetera. Trying to figure out how do we stop paying for it, not only the low value care, but the other services that are generated as a consequence of low value care. So that's the 50,000-foot view, Cliff.
Thanks, Mike. Let me just stick with you for a second, just kind of looking ahead. Based on your experience today, Mike Maddalena, have you seen any inkling of something that you'd like to kind of scale up broadly at a regional, national level, something you think is workable and can be broadened?
I think so. I think where, it's interesting. There's quite a range of where people's minds are in low value care. I think as we're able to measure it and demonstrate it, the effects more, I think we'll have better luck scaling this thing. I think there's the numbers are so big. We can save 2% of big numbers. That's a great day's work. So if we can do that, but I think so. I think the first task, the thing I've been having not trouble with, well, yeah, trouble with. It's been difficult to convince people in policy decision-making positions that, what the effect of this is. So I think we're making progress. I mean, we've been, like I said, Mike and I have been, Chernu and I have been thinking about ways to get this into RFPs, and it gets difficult where there's a perception you're withholding care. And it's like, well, it's bad care. Well, why do we want that? Well, good point. But anyways, it's been a process, and I feel like we're making movement on it, but it's been slow.
Okay, well, there are some good examples out of Virginia and Emblem. We're going to hear about those today, and we'll hope that you'll kind of reflect on those as well. Speaking of Chernu, let's go to Mike Chernu. Mike?
I just wanted to say one thing about the work I've been doing with Michael. He sort of alluded to this, and he certainly alluded to this in his answers to your questions, Cliff. But one thing I have learned, and I think many of you know this, and several folks on the phone may, understanding the barriers, why it is so hard for people to actually do things that will eventually even directly save them money is remarkable, because the nuances of the contracting process turn out to be unbelievably important in getting people to reduce or save, not even reduce, but even to save money by not paying for at least a portion of the low value care. And a lot of the stuff that Michael has been talking to me about, and I've been talking to Michael about, is how the contractual problems, particularly in the public procurement world, but I think more broadly, have limited access to things that people who are academics think should be no-brainers. So that hopefully will come up as we go through, and certainly hopefully it'll come up in my session with Josh.
Okay, well, we're looking forward to that. Thank you. I noticed that Dr. Amoroso is on. Dr. Amoroso, are you new to this crowd?
Sorry, excuse me. I am in fact new to this crowd.
Okay.
The invitation to this meeting was actually forwarded to me by one of the folks in my organization, and with a suggestion that, hey, you might want to go to this. I thought I would like to go to that. So
Okay.
yeah.
Tom, could you identify your organization and your role?
Of course, I'm sorry. Point 32 Health. That's we're an insurer in Massachusetts.
Got it. And just say a little bit more for those that aren't familiar with the number and what you used to be called and so forth.
So Point 32 Health, yeah, that it's a mouthful. Is the product of a merger between Tufts Health Plan and Harvard Pilgrim Healthcare. It used to be Harvard Community.
Right.
Here in Massachusetts. Those two organizations were longtime rivals, I'm going to call it, and came to the conclusion that they would do better combined rather than arguing with each other.
Got it. Thanks, Dr. Amoroso. Excellent point.
Tom, please.
Okay, Tom, good. Is there anyone else on the call today who is either new or who has some quick 30-second, 1-minute long update that they'd like to share? I do think we got the new folks on here. Any kind of 1-minute updates from anyone else along these lines before we jump into the main program?
I'm a new member, so just thought I'd introduce myself. Hello, everybody. My name is Austin Chang. I'm the CEO of Gramercy Surgery Center out of New York City. We're a private multi-specialty outpatient surgery center with one location in Manhattan and one in Queens. I'm lucky enough to take it over from my mother, who founded the surgery center. Actually, unfortunately, she passed away right before COVID. So I gave up what I was doing. I was actually a lawyer on active duty with the Army. Returned back home to New York, took on operations of the surgery center. And we've been working on certain value-based initiatives and costing initiatives. So we're really excited to share about that today.
Austin, if I may, and so sorry about the passing of your mom, but it seems that she had a good handoff to make to you. Can you just say just a little bit about what inspired your mom to get into this early on in the first place?
Yeah, so she was the practice manager for my father, who is a podiatrist. So it was one of those classic, situation setups. And I think, I know that she grew his practice substantially, and I think they quickly realized that my mother was the brains behind the the operation for them too. So one day, my mother, sort of woke up and said, I'm going to start my own business, stepping down from practice management and going to apply for a CON, which was, in New York, it's quite a difficult thing to do, especially if you're, not a surgeon. So
Sure.
she applied for it. She made the case for it in the traditional certificate of need sense, in that there was a need for operating rooms, in this part of the city, and New York granted her the CON. And from there, she used what she learned from managing my father's podiatry practices, understanding that there were surgeons that did not have access to steady, operating rooms and scheduling times at facilities, recruited some surgeons, and it took off from there.
Got it. Thanks. So she was into increasing access to high value and sort of minimizing low value where she could. Thanks, Austin. And I think we're going to hear a bit from you a little bit later on,
Yes.
along with Carol Huffman and Jeff Flynn. Thank you very much. Other comments, any other 1-minute updates from anyone or anyone else who is new to this call?
I have
Louis.
I have a 1-minute update. There's an interesting article in Reuters today that said physicians are not recommending the use of the beta amyloid targeting drugs for Alzheimer's based on essentially low-level evidence and a lot of controversy about their approval at FDA and things along those lines. Now, this may be a more extreme example of low-value healthcare because it's gotten a lot of press and a lot of action, both by political appointees and others. But it is interesting that if we're looking for physicians to, sort of hold the ground on this, and patients also to hold the ground, because I say this as a Medicare beneficiary, I will blame my fellow beneficiaries for a lot of the overuse of anything in this country, because I think personally they're somewhat delusional about what happens to us as we get old. So there's certainly blame to share there. So it's sort of a co-conspiracy without the conspiracy part of, people say they want something, someone can make money giving it to them, and they kind of ignore the other reality. But this is at least an interesting example and a high profile one.
High profile and very high volume potentially. And so it could be a low value care intervention that may be subject to very, very high volume, which has a lot of downstream effects as well. And I see that Mark Fendrick is going to share that Reuters article. Thank you very much.
Hey, Mark, you don't have to call me doctor.
He does for the first time.
Yeah, sure.
Louis, really appreciate that insight. And gosh, it's right in our faces. Randa Deaton from PBGH, a comment, please. And welcome.
Thank you. Hello, everyone. My name's Randa Deaton. I'm the Vice President of Purchaser Engagement with the Purchaser Business Group on Health. We're a national employer and public purchaser coalition. We will soon be releasing our third common purchasing agreement, which are contracting standards for purchasers. And it will be on maternal health and birth equity. So we are in the final edits of that, and it will have a payment reform model to it. And so I'm saddened to miss Michael Chernew's presentation. I have a conflict at that time, but I am really interested to hear what you're thinking about around contracting standards to drive better value, because we have been doing that for primary care, pharmacy, and then soon to be maternal health and birth equity. So I'll stop there just to say, hopefully you'll see it in the next month or so.
Randa, so glad you mentioned that. And when it does come out, if you wouldn't mind, if you could let Susan Lynn at VBIT Health know, and or others, we could help disseminate that. I'm so glad you brought that up. And again, PBGH has been a long time and highly involved member of this activity. I do see Ira Klein with hand raised. Ira, even if you didn't raise your hand, I was going to call on you because I just want to hear briefly about how where you are these days, which is kind of an interesting place, might reflect on low value care. Ira.
Thank you, Cliff. Well, I've been for the past 2.5+ years at a cancer genomics company that really is a tech company, at Tempus AI, and I learned a lot of genomics. And To Louis's point, one of my projects is looking at what is of value to large purchasers of healthcare, be it CMS in the public space or employers in the private space. And I find that this whole soup of mixed messages makes it very difficult to get a value equation together. But I think that we are at a point where we're having effective conversations with those on the employer front about why today, maybe not 5 years ago, but today, we're not really happy with the commercial insurance policies around genomic testing because they're actually driving lower value care in the form of subverting the drug therapy choices to giving everybody immuno-oncology drugs if they're not getting the right testing. And there's going to be some literature, more literature out on that in the future. And in terms of literature, just want to say one of the things that I've heard from those on the insurance side is, well, if you do a huge 400, 600 gene panel test and send the answers to doctors, you're inviting them to do crazy therapy choices. So in the next few months, it's on the editing desk right now. I'm publishing an article. I'm down there in the author list, but I wrote the manuscript looking at non-small cell lung cancer and showing that when you do comprehensive genomic profile testing, you're getting in non-small cell lung cancer about 85 to 86% adherence to NCCN guideline therapy. So large gene testing does not make people go crazy in cancer. It actually makes them stick to the knitting and using evidence-based medicine. So I'll stop there, but my last comment is to Louis's remark about senior citizens being delusional about their aging. I was at a recent meeting. I met Cliff. I saw him exercise. He's clearly not getting decrepit. If you need any heavy things lifted at your house, call Cliff.
All right. Thank you, Ira, but I was sweating trying to keep up with your pace. I'll just leave it at that. Thank you. It's great to hear from you again, Ira. And by the way, thanks to John Maffei for adding a bit of literature on some of our interesting Alzheimer's drugs. Thank you very much for that. And Ira, also thank you with regard to genomic testing at a large scale. That is opening up opportunities for a lot of low value care to enter the fray. And so we've got to be quite careful and thoughtful about looking for the right evidence, where does it work and not, so forth. So great. All the more reason to look forward to more work for all of us to do. I want to move now. Thank you all, by the way, very much for your comments. We're right on time. We now want to move to Smarter Care Virginia and its preliminary results. And it's my understanding that Beth Bortz is going to kick us off here, and she'll be followed by some input from John Maffei and then Steve Horan as well. So those three. Beth, you have been a shining star and a leading light in this field. We want to hear what you're up to with Smarter Care Virginia, and then get some insights about where it points us next. Beth Bortz,
Excellent.
everybody.
Thank you so much, Cliff, and thank you, group. Can everybody hear me okay?
Yes.
Good. All right. Well, this is always like coming home, sharing, what I'm doing with the folks that actually get it and get why it's important. So I enjoy these opportunities. My job today is just to set the stage. You'll recall I am the non-academic in our group. I am just the one who wants to get something done, and to actually fix this as a policy person. So here in Virginia, you may recall, because I've shared with you before, but some of you are new, we actually received a grant from Arnold Ventures, a little over $2 million back in 2019 to launch a statewide initiative around low value care. The timing, as you will see and you'll hear from my co-presenters, turned out to be a little problematic because we had a little thing called a pandemic in the middle of our initiative. So I just need to set that stage for you. We launched the active intervention in December of 2019. We had to pause it in March of 2020. We restarted in September of 2020, but recall that it wasn't like the pandemic was over in September of 2020, and the active intervention ended in December of 2022. But despite the fact that we had that challenge, we had more than 1,000 practice sites in the Commonwealth of Virginia with more than 7,000 clinicians participating in our initiative. Steve, if you'll go to the next slide for me. So just a reminder of kind of what we designed and what what the plan was. We had a clinical learning community that was, working together. And this was actually the first that these systems, worked on low value care outside of their own system and shared information with others in the Commonwealth. Then we had an employer task force, and we brought together 16 different employers, large employers mostly in the Commonwealth, because we knew that if our providers did the right thing, the challenge that they were going to hit is Mike Chernew's problem, which is they're actually going to lose money. They're getting paid in a fee-for-service world for doing these things, and we're asking them to do things where they actually reduce their income. And so then we wanted to work with both groups to develop a long-term plan. Steve, if you'll go to the next slide. So I mentioned the number of sites. If you're familiar at all with Virginia, you'll see that these are, 6 large health systems in the Commonwealth that also include 3 clinically integrated networks, which brought in some of the private independent practices in the communities as well. Next slide. And again, just to give you a sense, these were the employers that served on our employer task force. And really, the challenge, if you look at it, I will say the shortcoming is not many small and mid-sized. That's because small and mid-sized don't have people that can serve on a task force, where benefits are a focus, of their day. Next slide. So what did we, say that we were going to do in this grant from Arnold? We promised that, we would achieve a 25% relative reduction in 7 provider-driven, and that's important. We chose measures that we thought consumers wouldn't come in asking for. These were things that providers had control over, low-value care measures. I will tell you, we added 2 more just to make things more complicated during a pandemic, but we added 2 more because our employer task force asked for them. And then you'll see here, there was goals beyond the relative reduction. It was teaching clinicians to use the data, improving understanding of which interventions are effective. We really couldn't find any good information on that before we started this initiative. We wanted to reduce the harm to patients from unnecessary testing, and we wanted to educate employers on the actions that they could be taking. Next slide. So here you will see these are the selected measures, and we've gone over these before. I'm happy to share these later, but really they break into a set of drop the pre-op, unnecessary preoperative testing measures, and then some treatment and screening measures. The 2 that were added at the end, if you're interested, that employers were asked to be added, had to do with low back pain. Imaging and opioids for low back pain were the additions. Next slide. And so now I'm going to pass the baton to our lead evaluator on the initiative, John Maffei, to kind of set the stage for what we have learned so far. John?
Thanks so much, Beth. And thanks again for inviting our team to present. I just want to talk briefly about a clinical case. This is a real patient. We'll just call his name Jim, who is 59, has a history of mild asthma and a painful abdominal hernia. And this is a case that's reflective of many cases across the country where he comes to a pre-op clinic and he gets an unnecessary chest x-ray. And this chest x-ray shows an incidental lung nodule. This is something that I've dealt with quite a bit as a primary care physician. So the surgery is delayed, and the patient has to undergo a CT scan of the chest to further characterize the nodule. And the CT chest actually shows that there never was a lung nodule. But now the CT scan shows an adrenal mass in the adrenal gland. So the surgery is delayed a second time. And then a dedicated adrenal gland CT is ordered. And that finally shows that the adrenal gland mass appears benign. And all this time, our patient, Jim, lived in pain for an additional 6 months. He was very anxious about the test results and the possibility of a new diagnosis of cancer. He received lots of unnecessary dye and radiation exposure. And the scans themselves cost double the cost of the surgery. I highlight this case because ultimately this is what this entire work is all about. I mean, the cases like this inspired my passion in this field of reducing unnecessary and harmful care to patients. And we presented this case and many cases like it to all the health systems when we were introducing ourselves to the health systems. And so if you go to the next slide, I can tell you, I mean, Beth has already given you an overview, and we had grand plans before the pandemic to run a big randomized experiment, historic, one of the biggest experiments to reduce low value care across the state of Virginia, with thousands of physicians and 6 large health systems. We had a step wedge randomized design, which basically means, if you're in the industry and you want to roll out an intervention, I'm just going to ask you as a researcher if you could randomize the rollout. Everyone gets it, but you just randomize the order. That's a step wedge randomized design, and it greatly enhances your ability to see if there's signal or noise. And it's really helpful because a lot of times interventions will have a delayed effect or a subtle or modest effect size that you can't really easily tell with just a pre-post look. These kinds of designs can help tease that out much, much more cleanly. And the primary outcomes that we're interested in on the quantitative analysis side is looking at really low value care utilization as measured by the Milliman MedInsight Health Waste Calculator. We're also looking at a number of secondary outcome measures like high value care utilization, perioperative adverse events, just to make sure that reducing preoperative testing isn't unintentionally causing harm, which we don't expect it will, because these are all low risk surgeries for low risk patients, and of course, total costs. So if you go to the next slide, this is basically the initial plan that we had, and Beth and I and Steve and Howard, we were meeting with the health system starting in late 2019 and August, and then we flew in over the winter into early 2020, and actually we were just having our last meeting with VCU Health on March 5th, 2020, which we almost canceled because of this pandemic. And ultimately, we had to just shut the whole thing down. So we shut down the entire Smarter Care Virginia. It was quite a unfortunate timing. So we shut down the trial. No more randomized trial. Starting March 2020, Smarter Care Virginia was sort of put to the back burner to allow, of course, the physicians and health systems to deal with the pandemic surges. And so Smarter Care Virginia was then resumed in September 2020. Here, you could go to the next slide now, Steve. And so we had to modify our study design to just be a sort of standard observational difference in differences design, which is just basically a fancy name of looking at the intervention group versus the control group and looking at their utilization patterns pre versus post intervention. And this timeline sort of shows you sort of the start date of Smarter Care Virginia, the pause date in March, and then the resumption date in September, although for the researchers' purposes, we're just going to say January 1st, 2021, the resumption date. And then the end date of Smarter Care Virginia is going to be the end of 2022. And so we're currently working through the analysis, and I'll tell you, it's been quite a challenge. It's very, as many of you know in the field, very challenging to attribute patients and physicians to hospitals and to health systems. Very, very challenging, and multiple ways to do it in a valid way. And so we've been trying to deal with the thorny questions of attribution, of attributing those 6 intervention health systems, and then also attributing the control systems. But if you go to the next slide, I'm pleased to announce to this group that we will be announcing and releasing our preliminary results to the public at Academy Health at a podium presentation entitled "A Statewide Initiative to Reduce Low Value Care, Smarter Care Virginia." And we're scheduled to present, I'll be presenting in Baltimore in the Access and Quality session on Monday, July 1st. So if any of you are in town for the meeting, love to meet you and love to discuss our results. So we're looking forward to that. So thanks so much. I'll pass it over now to Steve.
Thank you, Dr. Maffei. I'm Steve Horan. It is good to be with you. I'm going to talk about a deeper dive into the qualitative work. By way of background, I'm the founding CEO of a group called Community Health Solutions, and we do research and consulting and training around community health improvement. And for many years now, we've been part of the extended family at VCHI and really honored to work with Beth and John and the whole team on this project. A little more context on evaluation. There are really two focal points. One, Dr. Maffei has talked about already, and that's measuring change in low-value care volume. I'm going to talk about the second piece, which is leading change for low-value care reduction. And all of this work is done in collaboration with the 6 healthcare organizations. And we started with an initial leadership practice guide. We added some insight to that initial practice guide and came out with a refined leadership practice guide. And that's what the rest of my slides are leading up to. I want to talk about the qualitative methods that we used. Again, we had this initial practice guide, which I'll talk about in a minute. We learned a lot from publications that came out in 2021, 22, 23. And Dr. Fendrick showed that slide earlier about this rising curve of studies in low-value care reduction. And we're actually learning a lot more about leadership and implementation at the ground level in healthcare organizations from the literature. So we really got some great insights from the literature just from 21 right through today. So that was great. We also wanted to learn, we had Smarter Care Virginia Project clinicians working on this. We had leaders from each of the 6 healthcare organizations. And so we did a series of 3 surveys with clinicians, and then we did 2 deep dive rounds of interviews with those leaders. And that's how we came out with this qualitative analysis. And so in addition to your standard frequency analysis of the multiple choice survey items, we were able to do a really deep dive thematic analysis of insights and ideas from these leaders based on the interviews. And I'll just spend a little bit of time here talking about how we did this thematic analysis. We can learn a lot from leaders in the field about how to implement low-value care reduction at the practice level. And, you know, if I could use 2 comments to summarize what I've heard so far is implementation is everything, and implementation is really complicated. So we asked ourselves, what could we learn from these leaders who are already excellent leaders? I mean, the leaders in Smarter Care Virginia, they brought a lot of expertise and experience to the table. So we viewed this as a learning lab for leadership. And that's how we designed these interviews. We conducted the interviews in the fall of 21 and again in 22. We recorded those interviews in Zoom. And those interviews are out at least an hour. We uploaded those videos into a software package called Trint. And Trint allowed us to do some very deep coding, word by word, of what they said about different leadership dynamics. And over here on the right, you can see what a Trint transcript actually looks like. And you can code it and you can mark it up. And the video is right there. So we're bouncing back and forth between the actual transcript and the actual videos of these interviews, trying to get a really deep understanding of what these leaders were trying to teach us about. So we did this analysis, we checked it with a team of people, and this is where we extracted our summary themes and detailed statements. So I mentioned that we started out with an initial leadership practice guide. You could read about this guide in a publication by Dr. Howard Beckman, Dr. John Maffei, and Beth Bortz. It's called the 10-Step Program to Successfully Reduce Low-Value Care. And it was published in AJMC in 2021. It's purposely not too complicated. If you kind of scan from top to bottom, the first 3 are kind of basic implementation science. You need senior buy-in. It's good to have an interdisciplinary team working on this. It's good to have clinical champions. The next few are focused on data, reporting, and conversations. It's really important to have accurate, simple reports delivering a clear, respectful message. The accurate is not as easy as it sounds, and the simple is not as easy as it sounds. There's actually some really creative design work that is needed to produce reports that can be shared with clinicians in ways that really make sense and prompt action. And then the next few are about conducting conversations and offering clinicians ongoing feedback through a dialogue. And I want to kind of point out Dr. Howard Beckman here. He was our kind of thought leader on this, and Howard has really deep experience in leading quality improvement projects, and in particular, low value care reduction projects in Massachusetts and New York and beyond. And Dr. Beckman was kind of the heart and soul of what we were trying to do. And he reminded us repeatedly about the table metaphor. Basically, as a leader, you're trying to create an atmosphere where you're sitting together around a table, and in the middle of that table is patients in low value care, and you're working together to try and reduce that low value care. The second it becomes where you're sitting across the table from each other as adversaries, that's when you begin to lose the clinicians, and that's when you lose their creativity. That's when you lose their support. And then beyond that, the need to build tracking tools and praise success on a regular basis. And that's more than a cliche when we say praising success. It's really a way for leadership to demonstrate that this is really important to do the right thing for patients, even if it means some financial loss in the short term. Okay. And Dr. Beckman would say, and also remind everyone that we should be doing more high value care, which should at least in part make up for some of that financial loss. So we started with that leadership practice guide. We went to work on the surveys and the interviews, and this is what we learned. That initial practice guide was relevant and feasible to implement. They told us that. But it didn't go far enough. We learned something from the literature, the frameworks we looked at, but we learned a lot from the clinician surveys and the leadership interviews. And to summarize, we learned that it's really important to focus on and do a good job of demonstrating leadership commitment, fostering a culture of trust, engage clinicians as partners, not just at the champion level or the department head level, but all the way down to the line level. Educate clinicians about the why and the how, and the why being more important than the how, especially when you're starting, and then provide supportive infrastructure, systems, workflows, et cetera. I could show you hundreds upon hundreds of statements, and I could draw a line from those statements to these 5 key findings, and that was the value of the qualitative analysis that we did. And so as a result of that work, we were able to come up with a refined practice guide for leading low value care reduction. Across the top, you see those 5 points. We call those leadership aims. You should be thinking about these 5 things all the time. They never go away and they're never done. These are constant aims that you're cultivating. And then down below, if you remember, our initial guide had 10 action steps. Well, we added a few more based on what we learned from the literature, from the clinicians in the field, and from the leadership interviews. I'll just focus on those. Those are highlighted in green. First, demonstrating leadership support, not just in general, but specifically for that guiding motivation of doing the right thing for patients. The next one we added was engaging frontline clinicians as guides for design and implementation. I think everyone here has learned over the years that clinical decision-making, it's a point in time in a particular situation in a particular setting, and it's very complicated, the sets of decision factors that come up for clinicians, right? And so they have a lot to teach us about how to create an environment where the right choice is the easy choice. 6, leadership thinking, anticipate and prepare to address obstacles to de-implementation. And going to the literature is really helpful for this, because you can see these obstacles that other folks faced in their de-implementation projects, and you can anticipate those as well. Number 7, leveraging organizational supports. It was really challenging to get IT support to work on this in some of the organizations because they have so many competing demands. So they need to be addressed early and often, but also things like the professional education units and other things that might be going on in the organization, workflow improvement efforts that can be focused on low value care reduction. Build into what's already happening in the organization in creative ways and do that early. And then down below, on number 14, align clinician incentives in ways that are consistent with doing the right thing for patients. We had 1 of 6 who was sort of ahead of the curve, and they were already thinking about, all right, we figured out how to do this. Now, how do we actually build in incentives to make the right choice of avoiding low value care, the easy choice, something that clinicians really want to do versus something that they, may fight against or at least be have mixed feelings about. And then finally, often in these projects, you start something, we had some cases where it was just a small group of people making a positive difference, which is great. But those pilots, there's a risk of those pilots dying out if you're not thinking about embedding them and spreading them early in the process. So for leadership thinking, think about embedding and spreading what works early in the process, because people work in big complex organizations and that spread process can take some time, and it's probably going to need a wide circle of people to get together and spread these kind of care models that are focused on low value care reduction across the organization. So I'm looking at our time. I will stop there and open it up to John and Beth as well as the group, and we'd be glad to have some dialogue, answer any questions.
We've got a few minutes if one or two people want to kind of raise their hand for any input or questions at this point. I just do want to call it, first of all, Beth, for your leadership that had really made this happen. John, thank you very much for the idea of explaining with a great example the iatrogenic cascade. It's not just low value care services in isolation. One often leads to two, often leads to three and more. So there really is a cascade. And Steve, thank you very much for kind of laying out these steps. And I really appreciate, I can tell you from experience, how you ran the qualitative analysis. Not easy to do. And kind of ginning up what you've had with not just a practice guide, a refined practice guide. You went from 10 to 15, you laid it out with a set of aims. That's like if you want to start building a program to go after low value care services, I would want this guide right in front of me, step one. So much appreciated. Any questions or comments here? I'm going to just kind of kick it off back to Steve. Steve, in going through this process, did you kind of run up into any hurdles or barriers that made you think, if we're ever going to do this again, I know how to avoid those? Sort of any learnings along the way about how to kind of get around or over some unanticipated barriers?
I think that when we look across the six, I mentioned one that was far ahead of the game.
Yeah.
They had built that data infrastructure and they had multiple meetings around performance measurement. And so they had a culture where people were used to using their own data to make their own decisions about how to get better. I think the main challenge here is getting started with data and reports that you can hand to a clinician in a way that helps them make their own decisions about getting better. It takes a while to build that stuff, and realizing that I need, for example, IT staff that are working on 50 other things. So that's where that leadership support really comes in, because somebody has to say, we are going to allocate IT resources for low value care reduction. Sometimes clinicians get caught, they're leading from the middle. They don't have the authority to do that. So they need leadership to do it.
We had really good insights on how these interpersonal dynamics work and translating that into a set of best practices. Beth, back to you.
I was just going to say, one of the things that I don't think I appreciated at the beginning, but that certainly through the interview process that we did, I learned was that it really mattered where these entities started. Where they finished depended on where they started, especially in a pandemic. Because if they kind of had the culture already, it wasn't as heavy a lift with the pandemic. Like there were things in place and they could kind of keep it moving forward. But if a lot of this was new, it was just such a heavy lift that they, at the end of the period, what they did do was realize why they needed this, and I think they made significant advances in terms of starting to set up the structure, but they're not likely. I mean, John hasn't shown me final numbers yet, so I don't know how it's actually going to come out. But my guess is from those interviews that they just couldn't catch up. There's a lot of infrastructure and culture build to this work.
Well, speaking of culture, we've noticed something that might provide additional value that you haven't kind of cited just yet. You have a variety of partners. that you showed in that one slide. And Virginia is a really diverse state. Northern Virginia is one planet, and I know that Southwest Virginia is in a different solar system insofar as the great variety of kinds of practices and economies and so forth. So did the diversity of the state of Virginia give you any insights about how to sort of handle this or sort of manage or take advantage of the heterogeneity insofar as laying out programs to reduce low value care? Any thoughts?
I'll let John and Steve answer this too. But from my perspective, I would say that if you were to assume that some of our more urban areas with academic medical centers would do better at this, you would make a wrong assumption.
Good to know. Thank you. Back to John. John, first of all, I want to just say thank you very much for the step wedge cluster randomized controlled trial design. And then you had to step back from that because of the pandemic. Do you want to say anything more about what you might have gained or lost going from the step wedge RCT to kind of more of an observational difference in differences study?
Yeah. So, thanks for that comment. And I think that, we probably lose a little bit of methodological rigor. And what that means is that, the 6 systems that volunteered, they volunteered for a reason to join. So there's something different about these systems. They may have different resources, different priority lists, and so there's different motivations. And so that could lead to some bias in looking at the effects. Are the effects of this program really from smarter care, or how much of it is sort of intrinsically there anyway in these systems without smarter care? Maybe they would have reduced some low value care without smarter care. So that's part of it. So randomization cleans that a little bit. So without that, there's a little bit of that, but you can somehow account for it by selecting a control group that looks very similar to the 6 systems. And I will say in our preliminary, I can't share the final results yet because they're too preliminary. But I will say at baseline, those 6 health systems, in terms of their low value care utilization rates on the 7 measures that we have, the utilization rates look pretty similar to the rest of the state at baseline in 2019. So they're starting from a similar place. And so so you can look at the absolute differences and compare apples to apples right there. To your comment though about what to do about from at least from a researcher perspective, when you're starting at very different baselines, if you're starting because of the wide range of health systems, then you really don't want to look at absolute changes. You want to look at relative changes.
Yes.
Relative to your baseline. How do you change? That makes a little bit more apples to apples. So but fortunately for us, we're pretty similar at baseline. And so utilization dips quite a bit, as you can see, but the question is, did the rebound of low value care land at a lower place for the intervention systems by the end of 2022 than control systems?
Thank you, John. We have to, well, I'll tell you, Kim, if you got a quick question, we'll fit it in. Kim Jeanette.
Yeah, very quick. Great work. And so I'm interested in a comment made earlier of how might you see doing this kind of work with organizations that are mid-sized and smaller employers, since they don't have maybe the benefits folks or the folks that you're including in your group. And that may not be a fair question to this group, but just I'm very interested in that segment because they tend to get not included for good reason, but interested in more work on that group as well.
Beth, what do you have for that?
I would just say, Kim, I'm interested in that too. So I don't have an answer for you. It has been one of the biggest struggles, but we do think it's actually through the plans. We have to get the plans as partners for that piece of it because the small and mid-sized, they just don't have the manpower and the control, really.
Well, that's still something to be learned. Well, big thanks to our Smarter Care Virginians. As I think John indicated, more to be learned and kind of with regard to the findings. Again, the Virginia situation is a very rich case study or set of case studies, content, methodology, quantitative and qualitative analysis, and just practical insights summarized very nicely in that refined practice guide. We are now going to move over to Emblem Health. Carol Huffman, I think you're going to kick us off, followed by Austin Chang and Jeff Flynn. Tell us about sites of care vis-a-vis low-value care. Carol.
Yeah, so what we're going to do is a little bit different. I like people over PowerPoints, and sometimes I actually use props. So get ready for that. I am very lucky that I work for Emblem Health and work for Karen Ignati is our CEO, and she's really a visionary in this area. Dr. Dal Cole was previously our CMO. He has been in all aspects of healthcare, including being a surgeon and, doing surgeries at an ASC. So we were really well positioned to take the site of care strategy to a different level at Emblem Health. We believe that you really need to think of it in terms of high value care. I like to turn the low value care on its end and say, it's really, I'm on a mission to spend the healthcare dollar wisely. Here's my prop for my dollar on high value care for all. And so site of care is one of the levers that you can pull to spend that healthcare dollar more wisely. And the other thing that made it really fortunate for us, and I have to give a big right on to Steve Horan for everything that he said, is because we lived it, is I am on the health plan side of Emblem Health, but I was able to come into the company actually assigned to work with our owned provider group, which is a fairly large primary and specialty care provider group covering all the boroughs and Long Island in New York. And so by sitting at the table with the provider group, I was able to really understand their perspective, their challenges, what they needed, what they wanted, what their workflows were about. And if you don't sit at the table and ask the questions, what do you need from both the member and also your provider community, then you really can't get any of these things done. So wholeheartedly agree with what Steve said. In this case, we knew we needed greater access for surgeries, and we needed to spend the healthcare dollar more wisely than spending up to 5 times to do the same surgery in a hospital versus an ambulatory surgery center. The providers wanted to be able to do their surgeries, with a shorter turnaround time, better quality. And so we really took the position of listening and being provider friendly, because again, some of you guys know I'm a beekeeper, and so you get more bees with honey. And so what we did was set up a concierge model, starting with Gramercy, and you guys can just Google Emblem Health concierge programs and you'll see a bunch out there. But we started with Austin and Jeff specifically because they also shared that vision and were working with providers in a similar way. The workflows, if you really listen to provider groups, they're on EMRs like Epic, and there are workflows and there are preferred provider lists that every provider group has. So if you listen to what they tell you, you can actually help them make their processes much smoother for their provider groups. So with Gramercy, Austin's going to explain to you how we did it and how they did it with the providers in the network. And then you're going to get a real treat because you're going to hear from Jeff Flynn. Jeff is he works with Austin, but he's actually the head of the New York Ambulatory Surgery Center Association. So I just happened to luck out with him on that. So he has really been influential in bringing ASCs into areas that haven't had them before in New York, like Staten Island. And he's also been part of the lobbying group in New York to try to make sure that as many surgeries as possible as can be done are regulated to be able to be done. And that's where I'd love to hear from you guys on your experience in this area, maybe in your states, and what strategies maybe you guys have employed. So I'm going to kick it off to you, Austin, and you got about 7 minutes.
Okay, great. So pleasure to meet everybody. Again, my name is Austin Chang. I'm the Chief Executive Officer of Gramercy Surgery Center. So we're a multi-specialty outpatient surgery center located in New York City. We have 2 facilities, one in Manhattan and one in Queens. We are truly multi-specialty, so a real alternative to the hospital or health system network. We do about 10 different specialties, so ophthalmology, gynecology, urology, ENT, pain management, ortho, podiatry, general surgery. So we do a lot, and I think that's what has made us a very good partner for payers and also large multi-specialty surgery center, surgical groups. So a quick note about the concierge program. So definitely a new concept that we were we've put together with Emblem. Primarily it is to put together groups of providers that think like us, that truly care about lowering the cost of care and targeting low value care. So that's really the genesis of this. There are specific things we implemented to make that work. For example, there's a large provider group, multi-specialty provider group that Emblem Health, I guess it's a subsidiary of Emblem Health, called Advantage Care Physicians, ACP. So, for example, for a group like that did not have all their specialties captured in-house, we provided a list of preferred providers that they could look at that we could vouch for, that we know are in network, so that there's not this bouncing around to out-of-network providers and things like that. And importantly, choose to employ modalities that lead to lower cost. For example, using our surgery center as opposed to being located within a hospital faculty department and performing surgery at a hospital. There are also different aspects of the concierge program that made it better for the members. We spent a lot of time working on the medical clearance between the PCP providers and the specialists and us, so that it's a little bit smoother for the patient experience, which we thought was great. And of course, we had a hotline that allowed folks to call in if there were specific questions. So that's the concierge program. And then, like we mentioned earlier, we also, Carol came to us about, it's kind of crazy to think about, it's like maybe a year and a half, 2 years ago now, about this thought to drop the pre-op for low risk surgical procedures. So we took a look at that. It took us a while to really get it ramped up and really operationalize it. I wish I had that manual from Smarter Care Virginia. That would have made my past 2 years a lot easier. So we operationalized one initiative. And we think it's really great because there's two, we're going at low value care from 2 perspectives. So one, there's the pure, site of care, surgical fee perspective. Cases are leaving the hospital and going to a lower cost surgery center. And then secondly, we were going after low value preoperative testing. So we looked at our medical clearance requirements, and we realized that because we're a multi-specialty center, we sort of had this, how do I say it? It's more of a, a preoperative testing guidelines that made sure we captured a safe medical clearance across all specialties. So it took some buy-in, like our previous presenters mentioned, buy-in from our medical director to carve out specific low-risk surgeries and say we are going to change the preoperative testing specifically for these sets of surgeries. And in this instance, it was cataract surgery. And we dropped, EKGs, blood, testing and labs and things of that nature, except for certain instances where they were indicated. So that required buy-in, not just from, the payer mentioning this could be a good idea, but we had to take that in-house to our anesthesia director. He had to be comfortable with it. And then we brought it to our the group that was working with us, Advantage Care physicians, and to their specialists. So we went to the ophthalmologist and said, hey, does it make sense before your surgeries that, perhaps we could drop these sets of, preoperative testing requirements? And they agreed, but they mentioned to us that it's not necessarily them that always, orders that testing. So we, kind of followed that string, and we realized that it's sometimes the PCPs, or sometimes not even the PCPs, but just this inertia of what the historical guidelines have been, and the managers of the process just say this is our preoperative workup, and this is just how we do it. So there was a lot of retraining, a lot of buy-in required, and that took us about 2 years. And the data, again, just like Smarter Care, Virginia, our data is also preliminary, but we have seen a pretty significant decrease in the amount of EKG and labs done before our cataract surgeries, which is really great.
And I'll jump in here for a second, Austin, because this was huge because Dr. Mafi was our inspiration. So got to give tons of kudos to Dr. Mafi. Years ago, he came in to our health plan and did a whole presentation. That was probably 6 years ago. I don't even know now. But Advantage Care Physicians is the group that, can pilot these things for us. But the health plan doesn't control that group. It's really all up to them. So Austin had to work directly with, Dr. Kurtz and Dr. Rodriguez, and he did a great job. The workflows had to be in place. The training has to be in place. So, to Steve's point, there's a lot of process that goes along with it. But you gotta be the gardener. You gotta plant the seed in order for it to grow. So, Austin, do you think we can pass it over to Jeff so he has time to kind of talk about what the procedures are? Okay.
Yeah, absolutely.
Thank you.
Yeah.
Great.
Hi, I'm Jeff Flynn. I'm the Chief Operating Officer of Gramercy Surgery Center, and I'm actually the Vice President of the New York State Ambulatory Surgery Association. One of the things with the procedures, it's access of care, patient experience, and cost efficiency, which we bring as centers directly. And I'm one of those who really do believe that if ambulatory surgery centers are used correctly, we really can drive these programs directly. One of our greatest successful programs at Gramercy is that we actually have an outpatient breast cancer program, which is a fast track program. And the fast track program of this is once a patient is diagnosed, if by the patient's choice, we can have them in surgery in 8 days. Sloan Kettering has a similar fast track program, which is 28 days. The key factor of this program is the patient has to join go to certain appointments and then directly go forward. But the key factor, especially if you have a younger patient, a patient in their 30s or 40s where the cancer is going to be more aggressive, the chemotherapy is going to be starting 20 days after the surgery. So we're already 20 days ahead of what the fastest program is to give the patient the best outcome possible that we have. Simply with different other procedures, it's a misnomer that we cherry pick cases or that we only take private insurances. As we've shown politicians and state leaders our centers, a lot of them ask as we walk through, oh, do you take Medicare and Medicaid? Of course we take Medicare and Medicaid. And we provide access to these patients across the board. So as I said, the one program which is key in this fact is we do probably 6 to 8 lumpectomies every single Wednesday. So that's a key factor for us to really support and move forward as we do a program there. We're doing higher acuity cases now too, which are through. We do joint replacements, we do knees and we do hips. And again, it's the cost of care itself in the sense of going forward. We're able to bring these cases at a faster track. In the hospital system, it's so traditionally as the hospital works, we work on efficiency. So therefore, we prepare for the cases the day before. We don't have emergency cases. All of our cases are planned out. So people aren't pulled away as they would be in a hospital. An anesthesiologist or a circulating nurse pulled to a more emergent case. So we kind of do our planned day. We efficiently track how the rooms turn over, so they turn over quickly. Unfortunately, in the hospitals, the average turnover time in New York City specifically is anywhere from 60 to 75 minutes to turn over a room. We actually can turn over a room in 12 to 15 minutes to directly get it done. So therefore, we're able to provide more access to patients and patient care as it goes forward through.
And I'll jump in here and just let you guys know, one of the doctors that performs orthopedic surgeries in the hospital, of course, they still, perform things in the hospital. That's appropriate at times. But he said to me that Dr. Kleeman, he's got these great YouTube videos. You can look him up on YouTube. He said, I can watch a movie in between the procedures in the hospital, and I can have, my next procedure done in, 20 minutes in a good ASC. So that allows him to stay productive in his day too. So, you've got to listen to who you're working with. But Jeff, could you talk a little bit about the challenges that you've had with CMS, allowing what procedures, and then the state too, and the different states? I think that's something that this group could maybe help lobby for in some cases. Everyone looks to CMS first, so what could this group do to continue to move forward and move the needle on high value care nationally, and then put pressure at the state level? So what are your thoughts on that?
Yeah, absolutely. There are certain things. CMS has an approved list of what we can get done, and that list is ever expanding as it goes forward. There are some challenges on the national level where the 20% cap on a Medicare patient is capped in the hospital outpatient at $1,600. There are 51 specific procedures where there will be a high cost implant or something put into the case, so that in instances that where the hospital may be reimbursed $34,000, the surgery center is only reimbursed $22,000. The patient's only going to have a cap of $1,600 to pay out of pocket, but by law, we have to charge the patient $4,000 because we have to charge them the copayment. So the patient is actually, the Medicare system itself, the trust fund is being charged an additional $10,000 is being paid out for that procedure because the patient can't afford the outpatient that would be required in an ASC versus a hospital. There is legislation on the national level. We're trying to get that changed so that we also have the same cap as the hospitals do. So we're working on that. But there's challenges in each state too, because all of the CMS procedures that are approved, like for instance, in New York, there are several lower end cardiac procedures that are approved for the surgery centers that actually New York State has public health law against. That's changed in other states recently. Pennsylvania most recently, Michigan before that, and the Carolinas have just changed. California and New York are both trying to get that changed in our states so that we could deliver more effective care. But also the savings to the systems are different. Like we're estimating if we could shift the lower end cardiac cases in New York State alone to the ASC setting for the appropriate patient, we can save the New York Medicaid system over $1 billion a year. So in these kind of cost-wise around, there are several states around the country that allow certain things to be done some follow that you can do everything that the Medicaid CMS list does allow you to do. Other states limit it. And so it's kind of going through and educating people and having them brought through the centers. The patient experience is always going to be better in a surgery center. And I'll tell you for one thing, there's not the chaos of a hospital. There's not the loudspeakers around. The patient's being brought in, and it doesn't matter if that patient has the best commercial insurance or they have Medicare or it's a charity case. They're going to be dressed by a smaller group of patients. The effectiveness also is because we limit the content, we don't have sick people. You see your loved one in the lobby. The next time you're going to see them is in the lobby again. You're not going to be bedside with the patient walking through the center. So our infection rates are so much lower because we really can control that, and we control access to the care itself. We have the fail safes in our sterilization all set up so that therefore we know when we're delivering patient care, our infection rates are literally, it's less than, I think it's 0.01% is really on average of it, where the hospitals average somewhere around 3 to 4% just across the board. So that's a significant in the difference. So there aren't additional costs for care after the fact in our situations and settings. And across the country right now, there's about 5,000 surgery centers. There probably needs to be between 9 and 10,000 surgery centers to actually provide access of care. There's one other example I want to tell you also, because Austin and I were presented this too. There's a particular part of care, and it came up during COVID. When we stopped doing elective procedures during COVID, we saw a spike in stage 4 colon cancer. We saw a spike in stage 4 breast cancer. There's a hospital system here in New York that they have a 3.5-month wait to get a diagnostic colonoscopy on a patient. So the trouble is, in that situation, unless you provide more access points to come into that point, that's where that's a situation. Where surgery centers are challenged state by state is some of the certificate of need laws have very strict, where the hospitals do kind of block the centers itself. I don't see us, I see us as an alternative, but I also see us as a partnership with the hospitals, because if the hospitals can open up their ORs to higher acuity cases where their patients have to be appropriately done, surgery centers able to do the cases of the healthier patients and the patient selected patients that come in, we can provide a lot more access of care across the board at a much more affordable rate. Because as we all know, the healthcare costs in this nation right now are unsustainable if we keep going, and we have to kind of turn the dial down by looking at other alternatives such as this.
Well,
Right,
Jeff,
and
thank you very much. Just Carol, just want to bounce it back to you. Can you provide a summary statement about the extent to which the payment system is lagging behind technological progress? There seems to be a lag there, exemplified in the ASC experience, correct?
You mean the payment system, like the Medicare payment system?
Sure, it sounded like.
Yes.
It's not keeping up basically with the state of the art, right?
That's right. And the states really need to keep up. You know, the states are going to cater to the lobby, the folks with the deepest pockets who are lobbying them to keep some procedures from being done in the ASC that they want to keep in the hospital. So there's that really needs to be tackled. And I think, again, because we look at the national level first a lot, that's why I, once a couple weeks ago went to Michael Chernew and said, what can you do? Is there something you can do to help? And that's why I'll hand it back to you, Cliff, because what I'd love to know is, what are people's thoughts on this? This is a huge issue. There's a big opportunity. What can a group like this do to kind of put pressure, to increase high value care and decrease low value care?
Yeah, well, I will say first that Tom Amoroso picked up on the glacial slowness, as he put it in his chat, with regard to payment trying to keep up with state of the art. And I just wanted to bounce something back. First of all, thanks to Austin for bringing up the concierge model and the kind of drop the pre-op thing. And Austin, it sounded like the time from planting the seed to germination bearing fruit was about 2 years, if I think I heard you right.
Yeah,
And then,
that's right.
Yeah, and then Jeff, just back to you. What was the single most important, what is, in your experience, the single most important factor in getting buy-in from the physician community to do something concrete about knocking down low-value care, or at least providing the opportunity for high-value care? What's the most persuasive take you can provide?
I think it isn't to buying into it really comes down to it's access. So like in certain markets, the physician's not thinking of the cost in most instances at all,
Right.
but they're thinking of their time. So like, for instance, as she mentioned with Dr. Kleeman, that he can sit there for an hour and a half between cases, his day's being wasted. He might do 4 cases in a day. He could efficiently do, in our situation, 6 cases. So he's sold on the fact of coming here and getting 3 hours of his day back. But also in the end, what comes with that, and time is of their essence there, but what also comes with it is that the cost based on this, because we make approximately about 56% of what a outpatient surgery in the hospital would be paid. We would be paid in the surgery center from a Medicare rate.
Yeah. Well, so just wanted to make that point, making the case that we're going to help you do what you're trained to do and what you want to do, freeing up your time in very clear ways. And good gosh, when you mentioned knocking down turnaround time from 60 or 70 minutes to 12 or 15, that's extraordinary. And that kind of argument, again, is persuasive. Just want to go to Beth Bortz, who had a question or a comment. Beth?
Well, first, I just want to say this is, great work. And, from the Virginia perspective, I would say I have been told that, the direction we need to go in by our partners is site of care. So, you're right in the right place. Because most of our partners have said, and I think somebody said, 2%, wouldn't that be great? But the comment I typically get from plans is 2%, the juice is not worth the squeeze, right? And why are picking tests and procedures. And so site of care is where the real money is. That's what I've been told. But I've also been told it's where I'm going to get the most resistance, that because that's where the money is, there's going to be a much harder pushback by certain players. And so I'm curious about that from your perspective. And Carol, you asked, how could we do this together? And I think we would need to do it together. Like, I don't think a Virginia could do this by itself. We would need to have other partners so that the plans really had enough skin in the game to engage.
There is something that Jeff touched upon earlier about working with the hospital systems. There are certain cases that exist that really don't need to be done in the hospital. And truly, if you free up those cases away from the hospitals, they would have more time to, perform, if they're in a fee-for-service world, perform those higher acuity, higher reimbursing cases. So take, for example, something like a cataract. We've been doing those in surgery centers for like 50 years now, right? And I think they're moving towards the office setting even. So I think, for example, a hospital even approached us, I think this was a year ago, basically saying they are so clogged up in their ORs that they would be willing to shift all their cataracts, to us, and sacrifice, their facility fee and only have the surgeons, build a professional fee so that they have that OR time to perform some of these cases where they have a real backlog. So that's just one point I wanted to touch on. But Carol might have more from the payer perspective. No.
Let me bounce it. I want to bounce it to Tom Amoroso, taking off from his chat comment. Tom, you're being quite pragmatic insofar as the what's in it for me angle here. So is forgive the expression, the target of a next move here, is it CMS and the state Medicaid programs, or is it the physician community? Where do we go next insofar as saying, listen, state of the art has way outstripped your payment systems. How do we make a real adjustment here? And, there's so many procedures that used to take days in the hospital, and they're now same day procedures. The patient community has accepted this as well. Where do we go next? Tom, do you have any suggestions aside from they'll do what gets them paid? Tom?
To some extent, I would argue embrace the power of and. because, the provider community, I mean, there's clearly an element of the provider community that's going to want to make a move to a different alternative and frankly less expensive sites of care because it's simply the right thing to do, to Austin and Jeff's point.
Right.
At the same time, so physician buy-in will come from both that and from the fact that there are, personal, I'm going to call them business advantages for them. That having been said, the issue of it, I always call it addendum E because it makes it very more specific. The inpatient only list is something that really has to be addressed on the national level, and that's where you can then leverage your buy-in from physicians to have them again, turn around through either individually or more critically through their professional societies, put pressure on the federal government to say, look, this list does not work. There was I believe it was last year or maybe the year before, CMS announced that they were going to eliminate, they were going to abolish that list. And then it didn't happen. And I was never able to find out why. Because I was applauding. So, but if that's the kind of, that would come around again potentially if, some of the professional societies would start, making a little bit of noise at the federal level. I mean, they all have lobbyists in DC.
So the two-pronged approach here, at least for this part of the argument, is the inpatient only list is something that may be eroding and maybe we need to kind of push to get set it aside permanently. And then the professional societies, whether it's making an argument of more efficient use of your time or something else to maximize your career, that might do it. I think, Beth Bortz, thank you again for elucidating your main concern about where the biggest savings are is where we might also tend to get the greatest resistance. So quick thank you then to Emblem, Carol, Austin, and Jeff. Wonderful presentation. You're really kind of sort of highlighting some of the issues we've got to pursue next. And that's a very nice setup, I might note, for Josh Fangmeyer and Mike Chernew here with regard to reducing low value care through an RFP process. So this is kind of a hammer here that Josh and Mike are thinking about putting in front of you here. And I hope both of you, Mike and Josh, consider what you just heard insofar as where the opportunities are and where the resistance may be found. So Josh and Mike, I'll turn it over to you.
I think I'm going to go first.
Yes, you are, Mike. Yes.
So don't want to looking for Josh. There's Josh on my screen. Yeah. So we have no slides, so we get to see more people, or at least see more names, and particularly I get to see Josh. I feel like I should say something about CMS and Medicare policy and inpatient only lists. I'm not going to. I'm certainly not going to defend them, and I'm certainly not going to talk about the broad, complicated politics behind them. But maybe I'll just say yes. I do want to talk about.
So noted, Chernew. Thank you.
I do want to talk about low value care, and I'll try and be brief, and then you can hear real stuff from Josh. So a few things. We know there's low value care, and a lot of the work that we've been doing as part of this task force, otherwise with several partners here, is sort of measuring how much low value care there is. And that's important. And I think in dollar terms, we've done a number of reports with states. We did a report with HCCI. There's a lot of low value care. And in fact, the low value care measure isn't really the whole consequence of low value care. Someone said this earlier, there's bad things that follow low value care, particularly the testing, care cascades and stuff like that. So I think we can agree that there's a bunch of low value care. Much of the discussion today, what we just heard, what John, Beth, and the Smarter Care Virginia folks were talking about really does show that we're trying to figure out how to get rid of it. And a lot of the work that we've done is about how to get rid of it. And I think we would all agree, and the reason we started there, because ultimately that was our goal, was to get rid of low value care. I'm going to ask a somewhat different question. It's a simple question. I'll ask it briefly, say a few things about it, and then turn it over to Josh. So the question I want to ask is, who should pay for the low value care? Who's financially responsible for it? So I'll give you three possibilities. One of them is providers. They deliver the low value care. It's hard to get rid of it, we understand, but if they don't get rid of it, they should just bear the cost of the low value care or some portion of low value care. That's option one. If I had a vote, I'd make you vote for these. Number two is the carrier should be responsible. It's part of their role as sort of fiduciaries, or their role in managing, probably more actually managing care. I've been involved in several RFP processes from the employer side, and in each case, the carriers would explain to us what it is that they have in their tool armament to try and make sure we're getting high value and not low value care. And to the extent that they're selling that as part of the RFP response, maybe the carriers should be responsible for paying for that if they fail to do that. And then the last group that I think I'll put on the table is employers, workers, taxpayers, whomever. They should just be responsible for paying for the low value care, because frankly, the carriers and the providers can't seem to get rid of it. It can't be helped. So someone has to pay for it. It might as well be the ultimate purchasers, which is the employers or their workers through lower wages, or taxpayers if it's a public program. So those are the three things. I'm not going to take a strong view, but I'll take a weak view that the answer shouldn't be the employers, the workers, or the taxpayers. That one way or another, the people in the delivery system, be they carriers or providers, are the folks that should end up having to eat the cost one way or another of low value care, at least a portion of low value care. And the question is sort of how much, how should that happen, a bunch of things like that. And I think that would be true if we were talking about, say, Boeing paying, or United paying for faulting Boeing planes. Who should pay for that? It should probably be Boeing, because they're making the planes. And I think that would be true for a lot of inputs that firms buy, that the producer is the one responsible for not charging you if the product they're selling you is some way low value. It's complicated. It's complicated because you need to figure out the process that you're going to use to shift the financial burden. My general view is that should be done through a performance guarantee. You see this in a lot of the commercial contracts. In our Harvard RFP process, we had an elaborate set of financial performance guarantees around patient satisfaction, cost trends. None of that focused on low value care. So we said we wanted less care in our performance guarantees, but not really less low value care. We were just fine with less. There wasn't a focus on low value care. That's sort of on us. But that's, I think, the mechanism by which employers hold carriers, and therefore incent carriers to hold providers accountable for the financial consequences of various things. There's concerns. The biggest one is we don't measure low value care with that much precision. Even in the case Austin was just talking about, they got stopped the pre-op, except in cases where things are indicated. So I don't think we are in a world where we want to just not pay for any low value care because there's measurement issues. So the question is sort of how much in the world that we're in. If you just cut 5 cents off the dollar on low value care, you would more than pay for any measurement tool that I'll talk about in a minute. And so you don't have to be that aggressive in what you don't pay for. But there is an issue about how you tailor the magnitude of any type of risk transfer to the carriers or to the providers. You're going to get a lot of pushback. I believe you'll get pushback from carriers, because who wants to take responsibility financially for things? I agree. They'll be concerned that it's too small. I understand. There's a lot of people that think it's not there. My general view, by the way, is if we waited for the big home run program, we just would not have any programs. Even in the ASC space, and we looked at some of this, and I'm a big supporter of ASCs and transferring things to ASCs, but by the time you look at the number of procedures and what you're doing, things get small fast. If you use the size to deter you from working, you'd never get anything done. So I'm not particularly sympathetic to that argument. Then there's the argument you can't eliminate low value care, and I actually think that some of the stuff we've heard this morning suggests that's actually not true. But whether it is or isn't true, my sort of response as a purchaser, and I understand that this is probably more econ-y than I would like it to be, but my response as a purchaser is not my problem. You can't eliminate it, that's fine, I'm not paying for it. And then you'll see exactly what can be eliminated or not. The last, or at least not paying for all of it. And the last point I'll make is, well, we'd love to be responsible for, but we can't measure it. And again, Dan Wolfson's going to talk later. I will agree there's some measurement nuance, but I think this wasn't discussed in detail, but it did come up in the Smarter Care Virginia discussion, where it was clear in the playbook that we need to have some version, some level of measurement, and Smarter Care Virginia uses the Milliman tool to do their measurement, and that I think was the backbone of a lot of what they did. So I see Beth still here. My screen isn't broad, so I'm not sure John or Steve are here. But in any case, so the point remains that there is a way to measurement. The measurement doesn't have to be perfect to do this, because you can titrate your the amount of risk to the nature of the measurement. And the last thing I'll say, which is sort of the problem for employers or carriers, honestly, even in delivery systems, we talked about sort of champions in the delivery system. You need a champion in the employer world. You need a champion in the carrier willing to take this on. And if you can get those champions, then I think you can actually move to just saying, look, we don't want to debate the many different ways we can or can't get rid of low value care. We just want the organizations that are taking on the responsibility of building an efficient healthcare system to bear some of the risk for low value care. And so with that lead into we need a champion, it is my intro to Josh from the state of Minnesota. He may have many titles. I'm just going to introduce him as he's the champion. So Josh.
Josh, what do you have for Mike's? And actually, Josh, before you get started, just want to make sure we capture Mike here. He's semi-rhetorically laid out who's going to take this on: providers, carriers, employers, taxpayers, et al. He voiced his preference. And when he voiced his preference, so I think for number 3, the employers and so forth, he said, go with performance guarantees. And he talked a little bit about how to go about doing that. In parallel, we might note that a 4th option, what came in from Louis Jacques, was stick it to the patients. They'll figure out what they value. So Josh, with that, we're going to hand it back over to you.
But before you hand it back to Josh, let me say, I didn't have patience, and I do, this is actually quite important. Most of the low value care, the preoperative testing stuff, it is just not something patients are going to be capable of dealing with. And it's certainly not something they're going to be capable of dealing with when there's, say, a requirement in the organization, in the system. If you want your surgery at this place, you need to get this test. You're not going to say, no, I'm not going to get the test. I think it's very hard for most, not all low value care, maybe vitamin D, but for most low value care, I think it's really hard to say the patients can sort it.
Thank you, Mike. We may hear some pushback on that from Jacques later on, but let's give Josh his stage here.
Sure. Well, thanks for the invitation. I'll maybe start with the who I am and why I think I'm here this afternoon. So I'm Josh Famer. I'm the Assistant Director for Plan Strategy. Although champion, I think I'd accept that title as well. So thank you, Mike. For the state of Minnesota. So for us, we manage the health plan for state government employees. So we have 2 different pools. We have the state employee pool, where we have about 130,000 members, most of whom are in Minnesota, but some in bordering states. And then we have about 30,000 participants who are in local units of government, school teachers, local fire departments, city employees, those types of workers. So we're all public sector. So all of our premiums are being paid either by a portion of it by employees or through public dollars from Minnesota taxpayers. So we have about 160,000 total members. It makes us probably the largest employer purchaser of healthcare in the state of Minnesota. And so we think a lot about what are the programs that we're putting in place, not only to serve our population, but what are some potential benefits of our decisions to like the larger healthcare system in Minnesota. And when we think about us as well as a large employer, so I said pretty large, 160,000 covered lives, we're self-insured, meaning that we bear all the financial risk for all the claims for our population. We have a set of tools that are regularly accessible to us when it comes to tackling things like low value care. I think for us, we think about benefit design. We collectively bargain for 80% of our workforce is represented by the union, and the details of benefit design are, a lot of it is negotiated down to specific copay amounts that we all work through with the CBA process. So that's one tool that we use. We've actually done some pilot programs with diabetes to promote high value care through benefit design. We also can directly communicate and provide education to all of our employees and their family members about how to use their benefits effectively, promoting different sites of care for different situations and putting that information out there. So that's another tool. But the tool I think we're going to talk most about for the rest of our time today is about the procurement process and what we can do to contract with vendors who are really high performing and can help meet like our strategic priorities. So as a public sector entity, we're under requirements to go out to procurement every 5 years for all of our contracts. So last year in 2023, we had to go out to RFP or do a request for proposal for our medical TPA or third-party administrator contracts. So essentially the health plans that would be administering the benefits for state employees. And one of the opportunities that we have is when we go out to RFP is to provide a sample contract. And within that sample contract, lay out the performance guarantees that we expect the new vendor to operate under. And so we use this opportunity in 2023 to update much of our old performance guarantees. So we've had, Mike mentioned some of the performance guarantees in his experience with RFPs. We also had very nuanced and complicated set of performance guarantees. A lot of things around operational performance, member satisfaction, cost control. But we view this as an opportunity to add more nuanced performance guarantees around low value care. And so our approach was to build in performance guarantees in 3 different areas. And we borrowed these from the top 5 lists that this group has developed over the years. So we have a performance guarantee related to imaging study for low back pain, low value pre-op testing in labs before low risk surgery, and vitamin D screening. And our approach is we're going to hold administrators accountable. So if they do not meet certain set thresholds for performance related to these measures and all the other measures that we have put in, they're at risk of losing 2.5% of their fees for each measure that they failed to successfully perform in. It's capped at 20%. And so what we're looking to do is create financial incentives through our contracts with our health plans to focus on these areas. And before I wrap up my comments on that, is our goal is not just to like reduce our TPA fees and for them to like fail, we pay less, and feeling like that's a good outcome. Rather, like we're thinking about this as a commitment device, both for us as the employer and the plan sponsor, and them as the plan administrator, to work on this together, to identify opportunities. Are there areas where we need to be working more closely with certain provider groups that maybe have higher rates of these low value care services or other approaches that we can work on these things together to get improvement and ultimately, if we're successful, to phase these out, maybe move on to other measures that we think can effectively improve our programs.
Well, thank you, Josh. So it sounds as though you do want to take a procurement approach. The idea is that using this idea of a sample contract is great. Once you start using that and gets picked up, and it might get picked up by others, it might be a very useful model as a point of departure. And your sample contract regarding performance guarantees starts as well with the 5 top areas that this very group, this very task force developed a few years ago. So that sounds like a very strong basis for pursuing it. Just Mike, back to you for a minute. Does what Josh described get after what you noted earlier about basically the RFP process. Is this the way to start to pursue taking a stronger stand on this and bring, for lack of a better term, bringing the hammer down, saying, look, not messing around, we're paying and we're not paying according to the contract?
So the short answer is yes. Yeah, sorry, I thought I was muted. The short answer is yes. I think the reason we have Josh here, the reason I called him a champion to start is because they have done what we have been advocating people to do. I think in all these things, you can't let the perfect be the enemy of the good. I think just demonstrating that you can do this, demonstrating that carriers will still, respond, I think is important. And so I think this is, let me say this. I don't think it is necessarily the case that there's going to be one ideal contract, one ideal system, one ideal way of doing this. I think every organization is going to have to figure out what might work in their setting. I think Josh demonstrated sort of the work that it took to get there. But the answer to your question is yes. What Josh did is an example of we have been arguing is that if you want to change the system, ultimately the purchasers are going to have to do where that starts because they control the setup and the environment that then flows down throughout the entire system.
Okay, well, very helpful. Jeff Levin Shirts, I noted you were rather adamant about your pushback on taking some patient skin in the game. Wonder if you wanted to comment, and then please take it the next step, Jeff, and that is, where do you put the hammer down? And do you like the model that Josh just described vis-a-vis procurement approach and the sample contract? Jeff?
So I think that the VBID the VBID group has actually had Frank Wareham on just a short while ago, going over the literature about how high deductible health plans, where members or employees in employer sponsored health plans, where members are have lots of skin in the game, and I think that that's shown in general that that under those circumstances, consumers actually edit out a lot of care, but they edit out high value care just about as likely as they edit out low value care. So
that point was made. You're right. That was. Yeah.
I think we sort of already have the answer on that. Not that there wouldn't be some instances like Provenge, which is in the comments where there might where people might make good choices, but there are just a lot of places where people make choices which are not based on the value. And yeah, so I mean, I love the way Michael has framed the question. I think that it is important to figure out who pays for it, and if we can figure out the right party to pay for it, then they're just going to stop it. And I think that since many of these decisions are made on the provider side, that being sure that providers are not making excess margin on low value care is actually most critical. I mean, I think that so I am in favor of contracts that put providers at greater risk to for delivering more low value care. I'm worried that considering the amount of provider leverage in contract negotiations, that if a major health plan says, okay, we're going to zero out, or we're going to pay it you only 10 cents on the billed dollar for really low value care, that what'll end up happening is that very high leverage hospital systems will just get that other 90% dollars somewhere else. Maybe that's still okay, because at least that will mean the low value care is low margin. And I mean, people often talk about how high value, how innovation doesn't disseminate very readily, whatever. And basically innovation that or new literature findings, if they lead to more margin, they disseminate very rapidly. If they lead to lower margin, then they tend to sort of languish. So I think having a margin implication of low value care on the provider side is the best way in my mind.
Jeff, remind folks your affiliation. I should have asked you.
Sure, I apologize. I should have said.
That's fine.
So I advise generally large employers at WTW, a big consultancy. I also teach at the Harvard School of Public Health.
Thanks very much.
So can I say something, Cliff?
Go ahead, Mike. You can raise your hand. Thank you. You're
Um,
recognized.
Just as an aside, when we started this, we thought we would be able to work through and just recruit employers, and employers would want to do this. And I should have known this from my experience here at Harvard, but I think it's broadly true that the role that benefit consultants play in the process of what employers do is unbelievably important. They control a lot of the measurement. In my world, they're the Congressional Budget Office of the employer side. They tell you what things will cost. They tell you what's hard to do, what's easy to do. They do the negotiations with the carriers in a lot of ways, kind of the behind the scenes bits of the negotiation with the carriers. And so finding thoughtful employee benefit consultants has been very, very high on our list. I don't want to imply that Jeff and Michael Madalena are the only thoughtful benefit consultants. That's not true. But I will tell you, we have spoken with a lot of benefit consultants, and there are two that I believe fundamentally are interested in both helping their clients and transforming the healthcare system in ways, whereas there have been other situations, I won't name them, where it is just easier to do the easier thing. And so unless you have very aggressive employers that are willing to really push, you don't necessarily get that kind of insight. And so I'm thrilled that Jeff's here. Michael had to jump, but I was thrilled that Michael was here. Finding an employee benefit consultant that's going to help ends up being an unbelievably important thing in this and a whole bunch of other stuff.
Well, if you're looking, we're all about practical tips today, and we had the kind of the 15 item refined practice guide earlier. Maybe that's item 16. Two things. I'm going to go to Lou.
Make it item 2.
Oh, okay. All right. Going to go to Louis Jacques next, just a moment, but I want to set up Tom Amoroso once again. Tom, you made some comments about what payers can do is tell the providers they won't pay for some list of low value services, period. Is that the kind of thing your plan is intending on doing? I just want to set you up for that, Tom. And Tom, any reaction you might have to Louis Jacques. So we'll go next to the fellow in the suspenders. Louis, please remind folks what you used to do over at CMS.
Sure. I used to run Medicare national coverage policy.
Indeed. Thank you.
So my team wrote national coverage determinations. We also developed FDA CMS parallel review. And a few other odds and ends related to compendia.
I can blame you
for drugs. Yeah, you can blame me.
You'll have a chance in a minute, Tom.
Yeah, the fundamental reason why Medicare does stupid things, in my opinion, is because Congress, fed by a huge lobbying industry, supported by patients who choose, in some cases, to be ignorant or to choose not to do their due diligence, essentially takes most good ideas and dilutes them down to the point where you're like, well, what's the point of doing it anyway? But anyway, the reason why I put my hand up was to explain why am I hammering this issue of patient accountability in the chat? And I am a Medicare beneficiary, Part A, Part B, and Part D. I don't trust MA plans. So I stayed in fee-for-service. No offense to anybody who's with an MA plan. But I really do think there's this tendency, and we did the same thing at CMS. We think of a Medicare beneficiary, and we think of some frail old grandma who's lived her life in prayer. She's never done a bad thing or said a crossword to anybody in her life. Old people aren't like that. People who were nasty when they were young are nasty when they're old, okay? There is this sense that, oh my gosh, these people should be encased in a little fluff ball and protected from everything. These are the same people who will absolutely stick it to you if they think it's in their interest to do so. So I think we do need to, I do think we need to be tougher on beneficiaries. I do think that because value is so individualized, whenever any of us tries to come up with value, it's like, well, who gave you the right to choose my value? So you tell the patient, that's fine. You want to choose your own value. You can take the upside or the downside of that choice. And the other thing I put in there about physicians and liability, yeah, it hardly ever happens, but if somebody gets sued, they're going to sue you or they're going to sue me. And the health plan isn't going to come by and be my defense witness. Okay, nobody else is going to come by and help. There was an article in American Family Physician about 20 years ago. There was a family doc who was into prevention, public health issues, public policy issues. And he took to heart all the recommendations that low-risk men should not get PSA testing. So he had the conversation with the patient. They didn't do PSA testing. Of course, the patient ends up having aggressive prostate cancer. And his essay was essentially about how his life turned to hell once he got sued. Admittedly, yeah, it's whichever heuristic it is, whether it's recency or convenience or whatever else, physicians are going to respond to that. Okay, yeah, it's a problem, but I'm not going to want who's going to carry it. So I'll close my hand.
No, that's great, Louis. Thank you. Before we go back to Chernu, Tom, I told you you'd have a chance to, for lack of a better term, rebut. What would you like to say in response? I think you might be on mute, Tom.
Yeah, sorry about
there you
that.
Go.
So I'm not necessarily sure it's rebut per se. Yeah, the problem, and I'm going to point out two things. First of all, I am, or was, if you want to say that, a provider in the real world. So I've been the guy who held the pen that wrote the orders, and that's kind of the point I was hoping to make, was that the providers are the ones who actually order the care. Health plans don't order the care, and there's a caveat to that, and I'll get to that. But the providers are the ones who are holding the pen that orders the low value care. And someone in the chat made the point that, this stuff pays for someone's mortgage or for their kids' college tuition. They're absolutely right. So I think providers need to be on the hook to some extent. Patients, and I'm going to now say the other thing that I was going to say is that the where I sit right now, I am the medical director for Medicaid in my plan.
Yeah.
And so that gives me a perspective that, is slightly different from Louis Jacques, only in that I'm dealing with a different population that is just as nasty, but not as educated. Just, potentially. There are some fluffy little old ladies. But so though that's the class of folks that I'm concerned are not going to know what constitutes low value care, and they aren't going to be able to access the kind of information they need to find out what's low value care, either for language barriers, education barriers, any number of things. So that gives me a little bit of pause in sticking the patient with the bill. So that, that whole thing basically is wrapped up, says, I think that the providers need to be on the hook for a whole lot more of it. And the last thing that I want to bring up is that there's an element of network and contracting that enters into this. That I know, I apologize, I forgot who it was, but I know someone brought that up. And the problem there is that, that person was absolutely right. There's going to be provider groups or folks who simply won't contract with you because you won't pay for their low value care, or will stick it to you somewhere else because you won't pay for that low value care. And I'm not sure, if you push the balloon in one place, it comes out somewhere else. So
well, fair enough, Tom. I do note that Carol Huffman is expressing her viewpoint on not putting too much burden on the patient. There might be a role, though, in better informing the patient about the downside, a la the iatrogenic cascade. Like, maybe you don't want all this stuff, and allowing them to opine on that. There may be an opening there.
Oh, I'm absolutely a fan of educating the patient.
Got it.
It was a big part of my job when I was providing direct care, and when I still do from time to time. But providers as a class aren't very good at it.
We hear you. Thank you. let's go to Cherno, and then Fendrick will weigh in as well. Mike, back to you.
Let Mark go first, since
okay. You yield the floor.
I've spoken.
Okay, we're yielding the floor to Mark.
So Cliff, just note that I've gone 2 hours without saying anything. So this is a new record for me. So Carol Huffman, we're so aligned, but Dr. Amoroso, you're my new best friend. Sorry, Cliff. I have to ask you this question. I don't know how many of your providers, and you are like me in a fee-for-service environment, right? So Cliff and I, you see both of us, we never ask a barber if we need a haircut. We have someone who in a fee-for-service environment will cut our hair every single day. So we, Dr. Amoroso, you're meeting us, have spent most of our lives using benefit design to encourage people to get more of the things you beg your patients to do. In the 10 years plus that I've been working with Dan Wolfson and Cliff and everyone else on low value care, and Mike, of course, importantly, we have found a substantial majority, if unanimity, this is provider driven, not patient driven. There are very few examples Louis, where patients actually come in and demand services they don't need. They exist, but they are rare
It
compared
happens, but it's uncommon, yeah.
really, really uncommon, which is why I really am going to side with you. Now you're on my screen as opposed to Louis, who I usually side with. Low value care is not a patient thing. It is not a demand side thing. It is counter to VBID. We've done a lot of work, Mike and I, on VBID for low value care. But the bottom line is, we know that the number one cause of medical debt in this country is medical care. We know the number one cause of online fundraisers is medical care. And we know the number one cause of personal bankruptcy is medical care. So patients, despite their skin in the game, will continue to do very dumb things if their doctors ask them to do that. And Mike's done some empirical work with other economists at Yale to show that, basically we're horrible shoppers and we'll do what our clinicians recommend, which is exactly what Carol said. So what I'm asking you, you're on my screen. I know your plan. It had 3 different names before when I was a medical student on the road. Are you willing to join the great Mr. Josh Fangmeyer to actually start getting serious about holding your providers accountable for certain low value care measures?
It would got a contract. We have a contract already for you, Tom.
It would be the highlight of my day. I'm not sure if I can free up the time for it, but I would absolutely be willing to do it.
Well, you could talk to, I think Jeff Levin Shirts is just down the block from him. You guys in Boston could make this all happen at Fenway Park and make the world a better place. So
we are, after all, the medical mecca of the Western world.
And what I think Point 32 is doing, although I haven't followed lately, just as an aside, is they have a bunch of risk contracts. Risk contracts are just one way of making the provider bear the cost of low value care. You don't need to necessarily go as granular. The problem has been that payers, Harvard, have not been able to get the carriers to do enough of that. In fact, I don't think they've been that. I really think this is that the employers have not figured out how to reward the carriers that are doing things you want them to do, or hold them accountable for things that are doing things you don't want to do. You could do this through risk contracts. If you wanted to do it in benefit design, I actually think that's going to be hard in most cases, but if you want to do in benefit design, it would be up to the carriers to figure that out. If you want to do steerage, so site of care policy in the commercial world, that turns out to be the employers have to buy that product that the carriers offer. The carriers will design, Point 32 will design a very well-designed tiered network if you wanted it, and you just have to have employers that are willing to buy it. I think at the end of the day, it comes to how you get employers to hold carriers accountable for holding providers accountable. There's that chain of activity. And I think the performance guarantees and rewarding carriers that are doing this ends up being important. And then back to Jeff, who now I don't see, or Mike Madalena here, getting
Jeff's on.
Yeah, there he is. Getting EBCs that will give credit to the carriers that are doing that in the RFP process. And I think what Josh really demonstrated is if you have employers whose eye are on the ball, you can get carriers to respond and do what you want them to do. And if you don't, you can't. And that, in the end of the day, I think ultimately we will agree that most of the low value care is granular enough that we won't get patients to do it. Just like a car, you buy a car, consumers are great at cars, they're not great at carburetors. But but you need employers to hold the carriers accountable, and you need the carriers to decide how they're going to engage the delivery system. And that's going to sometimes be risk contracts, sometimes be prior auth, sometimes be bonus systems, sometimes the education programs.
Well, Mike, do we now have, though, actually, I want to pose this to Kim Jeanette. Kim, because you asked a very good question earlier. Kim, in your estimation, have you heard enough that would persuade you that we have the tools to pursue this? The tools being the history of choosing wisely, and we're going to hear about that pretty soon. The top 5 and other topics that the Low Value Care Task Force itself developed, which were incorporated in writing in performance guarantees and model contracts by Josh et al. To design into similar tools and requests for proposals to bring this hammer down. It sounded like Amoroso is ready to buy into that. Jeff Scherzer also sounded like he's in favor of it. Kim, from your standpoint, are you seeing enough of this constellation of tools and so forth to make this work?
Well, thank you for asking me the question. I feel like there's a lot of other experts on the call that could probably answer it more effectively, but something that Mike said earlier or put in the chat is really jumping out at me, I think, because of my experience with employer and payer coalitions and working with them, is around the consultants. And employers most definitely, 9 times out of 10, don't quote me on that stat, really defer and rely on their consultants' recommendations. So if we don't target, sort of to Mike's point, those who are kind of going in the direction we want them to in terms of reducing low value and improving, direction to high value among the consultant groups. And I'd say that's not just the firms, but the individual consultants as well, and sort of what spaces they're targeting. Then I don't think we're ever going to get like the employer payers on board at all. And I know that leaves a whole other segment of the market still, what do you do with them? But I kind of like this idea of a really more targeted approach among the consultant groups, just to see if there could be some better movement with an RFP process, or these sort of, even the concierge idea that could be part of an RFP process. If you want to be part of the concierge service, you have to, meet these, goals if you're going to be part of it, or meet this in the contract, do these things, not do these things. So, yeah, I'd really kind of love to hear more about that and hear where that's working well.
Well, it sounds like you're building into this. Another important element are the well-informed consultancies here who have experience in this, who aren't afraid to kind of push forward this. And it sounds like employers and others would put a lot of stock in some cohort of well-recognized, proven folks that, along these lines. We're going to take just maybe, Josh, if you could kind of wrap us up here, after which we're going to take a break and then go to Dan Wilson for trying to go forward with his experience. Josh?
Yeah, I guess I can share just a little bit of insight into our EBC experience. So we have Deloitte as our consultants, and they're really good, but they didn't bring this idea to us. Like this is something that we put together ourselves as the employer. I put a link in the chat to an extract of our RFP document, and you can see in there, like, we have links to VBID Health resources, including like the specifications of the low value care measures. So while I do agree, like getting the EBC community to push this model for procurement could be really helpful, I don't want to let like other employers off the hook either. Like they have to really care about this and make this a priority themselves, and not just rely on their consultants to push it on them.
And I don't mean to interrupt, Josh.
Go ahead, Mike.
And it's not even, I don't expect the EBCs to push it. It's been amazing how much they've resisted it. So like, I won't speak to firms other than the ones that are represented here, but they have jumbo consulting teams that come up with what they're going to do for all their jumbos, if you will. And if that changes or gets more nuanced, that is hard. And they're balancing what the carriers want and what their jumbos want and a bunch of other negotiations. And so I won't go through the details. We went pretty far down a number of paths in this process. And when you get into the sausage making of that work, it's Deloitte, quite frankly, is outside of the set of consultants that we were working with. So maybe that I need to talk to more people at Deloitte. But it wasn't that they weren't pushing it. We were just trying to get them not to resist it.
And Mike, the
hard.
point this is a very useful point, because a key player, for better or not for better, may be the EBCs, and maybe there is an emerging cohort of EBCs that really know how to do this, that get the nuances, that have the experience, and can kind of get the kind of Yelp positive reviews to have others kind of sign up with them. Okay, well, Mike and Josh, you really set us up on a lot of great back and forth here. We're going to take a break now to the bottom of the hour. When we come back after a break, I'd like to engage Dan Wolfson in a fireside chat. He's lined up some very interesting points that we want him to make. And we'll also ask him to reflect on where we want to go next. There's a lot to be learned from Dan on this, both retrospectively and prospectively. So we'll see everybody at the bottom of the hour, 2:30 Eastern. See you then. Well, I think we're reassembling now. Thank you very much. I must say that having had the privilege of helping to facilitate most, if not all, of these low value care task force meetings, I'm stimulated and encouraged to hear the back and forth on some of these issues and how we're really trying to focus in on where the opportunities lie for making further progress, who the best receptor sites are, and what instruments we might want to use to kind of address those. This is a really important set of steps, and always appreciate the back and forth and kind of the realistic perspectives that our participants bring. With that, Dan Wilson, welcome, welcome, welcome. In some ways, we might not even be here without the work that you've done with ABIM Foundation and so forth. And it would just help us so much in the next not quite 45 minutes. If you could provide us with just a bit of background on how kind of thing just got started with the foundation. What was the motivating set of factors? And then more on how you experienced what you experienced, in particular, kind of lessons on the upside, lessons on the downside, and then the barriers in particular that you confronted and sometimes circumvented. And then one more kind of question for you, and that's going to be something along the lines of, although we know you're not with the ABIM Foundation now, you can still provide us a broad perspective about where the field needs to go next. And I know that you were listening quite intently to our program thus far, and perhaps you heard some things that you might integrate into your perspective. So some retro, some current, some prospective. Dan, can you get us started? You might still be on mute, not sure.
So imagine a world that I was in the 80s, working at a health plan. At that time, a guy named Norm Levinsky, who used to run the Evans Medical Clinic, wrote in New England Journal of Medicine that physicians should not be at all concerned about the cost of care. That was not their responsibility. And in fact, he stated, and he was a very thoughtful individual and a leader in his day, he felt that physicians should give everything that a patient would want. So we're going into the ASA, and everybody's thinking about how they can solve the affordability issue. And all the people are thinking, well, this is going to lead to...
She's at Twin Cities in Niceville.
Hey, Thomas. You might want to mute, Thomas. There we go.
He's on mute.
Okay. So where was I? So people are thinking at the time of the ASA, physicians are going to ration, and they're thinking about death penalties. And there was hysteria about what this was going to mean. And I don't know if people remember this time, but it was around 2010. We are an organization, a foundation connected to the American Board of Internal Medicine. And very frankly, we kind of are the profession. We represent the self-regulation of medicine. And the foundation has a document, a physician charter, that talks about the responsibilities of physicians. And we begin to think about what can we do in the area of managing resources. And that was a part of the part of the physician charter. And the physician charter was different because it went beyond what responsibilities a physician had to their individual patient, more towards organization responsibility and society responsibilities. So then we get an idea that we adopted from a guy named Howard Brody. He is a medical ethicist from University of Texas, Galveston. He wrote an article saying, where are all the societies regarding this affordability issue and being a player in the ASA? Silence was the issue, mostly some opposition. And he suggested that specialty societies should identify 5 things, 5 tests and procedures where the benefits didn't outseed the risk. An organization that no longer exists, the Physician Hospital Alliance, a guy named Dr. Steve Smith from Providence, Rhode Island, we gave them a grant, and they in fact did it. And then we turned around and said, why don't we ask the specialty societies to do this? So they did it. They did it, 9 of them in the beginning, 45 recommendations. We probably should have stopped there, right, Michael? And we should have just stopped there, and we would have been better off in some ways. And those are the ones that you hear about all the time, at that point. But we introduced 80. If I have any regrets, I wouldn't have let anybody in that didn't meet a barrier or a threshold of really being serious about their recommendations.
That's actually not a bad take-home point. I won't keep interrupting you, but so
Yeah.
noted.
But at the time, it was about how do we engage physicians in a conversation about low-value care? And we didn't use that word low-value care. We used different language. And a part of the beauty of choosing wisely was the language and the framing of the issue. And we didn't say low-value care. We said, make wise choices, have conversations between patients and physicians. It had the beauty of it was in its communications and framing, because what we were trying to do was normalize the fact that physicians to take responsibility for resource use. And at the time, that was profound. And it was profound, and it got a lot of publicity in the beginning and a lot of expectations, Cliff, of what we could do. But what we were trying to do is simply have a conversation about it. And the recommendations were to make it more concrete. Because what we were trying to do is cultural change. And cultural change comes through conversations with people, with leaders, and the specialty society saying, these are 5 things that you shouldn't do. It was a story of dog biting man. If you want to get attention, you know this, Cliff. It's the unexpected story. It's the unexpected behavior that gets attention. And that got a lot of attention because it was the unexpected behavior of the physicians, essentially saying that they were doing something not in their economic interest. Their economic interest is to do more. So we were about inclusion. We were about conversations. We were not about absolutes. And to the chagrin of Mike and the 2 M's.
Mike and Mark.
We didn't want the health plans to get involved. And the reason why we didn't was we didn't want to make it about cost. We wanted to make it about quality. And we wanted to make it about safety. And we wanted the physicians, for once, to get ahead of the game. Now, Michael and Mark know that I was involved in the beginning of HEDIS. And that came from the health plans. And by the way, it came from the employers more than anything. And I can remember Xerox taking a real leadership role in HEDIS. And I'll never forget the role. And every time I get in front of a employer group, I tell the story of HEDIS because it was an employer-led leadership role around quality. And I think that is gone for the most part in American medicine today. So anyways, that tells the story. I'll stop there, Cliff. I probably bored Mike and Mark.
Dan, you didn't, and I don't want to let that last point go about HEDIS and employers. It kind of suggested, were you suggesting we kind of give up on employers or?
No,
or
I
what?
think that the employers need to reinsert their leadership role. One of the things, Michael will appreciate this. Doris Mitchell. Does anybody remember Doris Mitchell? Michael, who's Doris Mitchell? He's not there.
He's coming back. Yeah.
Doris,
From the Boston Contingent, I'll tell you, Dolores Mitchell was the very long time executive director of the Group Insurance Commission, which purchases health insurance on behalf of Massachusetts employees, retirees, and lots of other quasi-governmental agencies and municipalities. And
yes, and on the board of NCQA for a time.
Yeah, and frankly, a force of nature.
And I don't know if she's still with us or not.
She is still with us.
Oh, good.
She's still with us. But
Well, the point of the story, I don't mean to get sidetracked. The point of the story, but thank you, is that in the beginning, Doris required all their health plans to come up with things that they were going to do to reduce choosing wisely recommendation. Pick some and tell me how you're reducing them. So in the beginning, Richard Barron, who I used to work for, said, we built a tool or we built an axe, but we can't chop down the trees. And so I was always discouraged, frankly, that more employers did not pick up, more health systems did not pick up. And in the long run, I'm getting ahead of myself a little bit, but you want to say, well, why didn't this all work? And by the way, a great story, Michael, that he was involved in, he had a student named Aaron Schwartz. And Aaron Schwartz did a paper about the Choosing Wisely recommendations, I think like the first 45. And it came out that we would save 2% on Medicare budget. And people said, oh, that's nothing. Look how small of savings that is. And I'm thinking, are they nuts? 2%? Michael, help me out.
2% of many, many billions of dollars.
Yeah, I thought it was amazing.
This is what I said. This is what I said earlier. If you're looking for something big, you're not going to find it most of the time, and so you're going to have to take a lot of 2%. And by the way, I think it's bigger than 2% when you add in all the
cascades
downstream and stuff.
Absolutely.
But it was only 2%, just straight up. Anyways,
so Dan, get to the point. Summarize for us. What did Choosing Wisely accomplish? Like, what's the kind of body of work in the end that says this is where we got, and then after that we'll talk about the barriers and overcoming certain hurdles.
Well, I'd love for others to chime in on this point, but what I think we got was a normalization that physicians are responsible for overuse. We got that this is their responsibility to do. They hold the pen, that this is a professional obligation, that they are absorbing a enormous amount of resources that's being diverted away from society. And then they had the opportunity and the material to do something about it. It wasn't just in the abstraction. We were saying, okay, there's overuse in America. We need to do something about it. We gave them 800 recommendations for them to then take and begin to think about. Now, what we got criticized for, and it just forward me was there's no such thing as a decree, and everybody would pick it up. Like, how long does it take evidence to come and really become into practice? 17 years, it's always said. And immediately we got criticized that in a year, all this stuff was not reduced. And I kept saying, how do you expect behavior to change by decree or just putting out information? And education alone is really the lowest form of behavioral change or quality improvement. It took system change. It took all the things that Beth was talking about, feedback, peer kind of conversations. We did a whole bunch because people were pushing us in this direction. It was not the original intent, but people were pushing us, and we got money from Robert Wood Johnson Foundation. And we looked at peer pressure, peer feedback, champions important, alerts from medical records, and order sets, all those things. And when I think got to it, and people would say, you know, it's really fee for service. That's the cause. You pay more. I mean, you do more, you pay more. And I always thought that was oversimplistic. And I think that all these system changes are trying to change habits, and habits that are put into physicians when they're in medical school and residency. And it's the heuristics of medical decision-making. Be thorough. Don't let any stone unturned. All those things play into it. So unless there's something, I'll just finish this. Unless there's something to disrupt it, it's going to continue. And we need to disrupt it. We need to disrupt it through system changes, through tried and true quality improvement techniques, all the techniques you can think of. But it is ingrained in them. And Michael and Mark, I agree that. And I get this, I was in the health plan field for 27 years. We need to reward people for getting rid of low value care. It's got to be a reward to do it. When I was at Fallon Community Health Plan, when I was 27 years old, what we did was every dollar that they saved on hospital use, we gave them half of that amount. You have to pay people to focus on something that's going to take a lot of effort and behavioral change to do. It's got to be a downside risk and an upside risk.
So Dan, the training in physicians was at least enabled or remains enabled by fee for service, of course. So we do know that if you switch out fee for service and put in another kind of incentives, they're more likely to kind of move off that original sort of training. Can you say a little bit more though about you had a hatchet in your hand and you targeted basically 800 trees. You couldn't cut them down. Can you say a little bit more about who took these recommendations and ran with them? In other words, you put them all out there. To what extent did employers or other stakeholders or gatekeepers run with them?
A lot of medical groups, hospital systems that were involved in, shared savings agreements. So we put it into 14 regions. Beth has done that. So I really think that the target audience is not necessarily the physicians, because I think it's the health systems.
Yeah.
And they're the target, and they're the target of incentives, of reward and penalty. Yeah, I think that it's really on the health system level. I've never been, I agree with Michael on this. I never agree that this is driven by patients. If it is, it's in small areas. It's probably antibiotics. Although I dispute even antibiotics as being driven by patients. So I'm of the camp of put the physicians, but really the health systems in a set of arrangement where they can get upside reward and downside penalty.
So that's very helpful. To what extent did you, to what extent in setting up these 800, reveal to you, or not being able to apply the hatchet, I guess, to the 800, where exactly did you run into a wall or a barrier? And we can kind of take that forward, but if you could identify the three main reasons why you couldn't chop down more of those trees, what were they? 1, 2, and 3.
Well, I think there wasn't the political will to do it.
Okay. And when you say political, do you mean on Capitol Hill political will,
No,
or do you mean,
small p.
okay, all right.
There
On the
wasn't
parts of
there
the,
wasn't any motivation to do it. It wasn't overriding for really, and I think we're talking about scale. So there has not been a method to scale this up.
scaling.
So scaling is really, I mean, you talk about scaling, and every problem that we try to solve, we can't scale, and we could not really scale choosing wisely. I want, my dream was for Beth to take this nationwide in every state possible, and to really work, a network of hospitals working together to improve care in to really take Beth's model and to expand it nationwide. So the scalability issue, the will issue, and the intractability of the health system. The things that were rationalized, like we can't do it, we're going to put us at risk for malpractice. All those resistance issues, I think, are red herrings for not wanting to change practice, and not wanting to be at risk for not getting that rare item. I always tell the story when I was speaking of the 4 EKGs for two detached retinas and 2 cataract. And I said to the anesthesiologist, a good Israeli, and he says to me, I said, why don't we make me schlep across town to get my 4th EKG and an operation for a cataract, which is like getting Nesta, intravenously, and I run 45 minutes. He says, I don't want you to be a 1 in a million, and you had a heart condition. I said, well, so I went back to my cardiologist friends and I said, well, what is that? Is that really right? He said, yeah, Dan, it's 10 million. 1 in 10 million. But we have the mindset and the training that tells us that we can't take any risk. No, it's just a DNA training.
Right.
And, I still get unnecessary care myself. I can't talk my doctors out of giving me unnecessary care.
Well, I hear you. The thing is, earlier today, John Maffey made that great case for the iatrogenic cascade in just the way that you described. Dan, meant to ask you earlier, the stars, what were the Choosing Wisely stars?
Oh, well, the Choosing Wisely Stars is a great program. It started a woman in Canada, Wendy Levinson. STARS stands for Students and Trainees Advocating for Resource Use. And it's still going on. It's in its 10th cohort. And it's really my hope for the future that you change, you got to get them young. And you got to ingrain them in some of the principles of their behaviors around resource use. So it's that generation that I think will cause the change that we want to see. I hate to say that, but we're in our 10th cohort. And these people are now people that that people in the audience would know. They're the Neil Shaws of the world. They're the Chris Moriarty's of the world, the Vinnie Aurora's are going around and really now in leadership roles that started out thinking about the concepts of choosing wisely.
Yeah.
And so, that's one of the accomplishments that I think is our legacy. I think our other legacy is John Malfi and other researchers that are really focused on low value care as a scholarly pursuit. So I really think that we helped with that, and research still goes on. I see articles coming out. So,
by the way, I think it was Jeff Levenshirtz who asked this question. Why isn't the ABIM Foundation still showing the Choosing Wisely metrics on its website? Was there some political thing behind that? I did notice, I think it was someone also mentioned that on at least one of the medical professional society sites, they're keeping theirs up. But can you talk about what happened to the 800?
Yeah. So this was supposed to be a 5 to 10 year campaign. So in 2017, the foundation turned its attention to trust. If you haven't read the New York Times this morning, there was a big article about the importance of trust. So, and we thought it was also very linked to Choosing Wisely. So as an organization, we said, are we going to produce the next 800 recommendations? We don't think that had use. We didn't say job done, but we said we did what we wanted to do. And there wasn't much to go beyond. Then we left, frankly, the recommendations up. And at one point we had to say, are we going to maintain these forever? Because it's not no cost to have the evidence reviewed on a yearly basis. And the specialty societies were doing that. And the recommendations were deteriorating. We weren't investing in the area. We're investing in the area of trust. So we decided, not anybody else, we as a foundation decided to take those down, and for the specialty societies to put them on their website and to own them, because they are, how many recommendations did the ABIM Foundation develop? 0. We didn't ever make recommendations. Those were the specialty societies. So we hoped that they would put them up.
Karen Johnson notes that the American Academy of Family Physicians does maintain them on their website, which is, of course, very useful. So, Dan, looking ahead now, and again, you're not speaking on behalf of anyone in particular, including the foundation.
Yeah.
How do we pull forward the Choosing Wisely experience and your observations of it, and sort of thinking through what you heard today, earlier today, into where we go next? How do we now take this to a next generation here?
Well, I'll take maybe some European models. We need a better evidence-based. And I know this will sound like heresy, but we need to have cost involved. We need cost effectiveness. Medicare needs to take cost into consideration. They need to legislate it. It's been dodged forever, going back to Nixon, that, everybody's proposed it, and every time it's come up, people have dodged it. So we need better evidence. We need organizations at the federal level developing the evidence-based. Should involve cost. 2, I really think that we've got to provide incentives and pay people to do the right thing. A third will do the right thing without incentives. The middle will follow, but the 1/3 will stick and not move. And so I really think we need to have financial incentives and have it in a positive way, in a negative way. I would begin slowly. I would begin by Doris Mitchell's "Show me what you're doing. It's coming. Next year, measure it. 3rd year, you're on the hook for it." Somebody gave me a big bubble. Who is it? How can you do
Sounds
that?
good. Sounds good.
So,
keep going.
that would be what I would do forward, and I would spread things like in medical education, it's fallen off the radar. I thought after COVID, when everything had shut down, and there was a guy named Dr. Dan Morgan who was trying to do this. Everything had shut down, right? Tests weren't being given. There wasn't any upswing of mortality from that. And we thought that maybe we would be at a point where, gosh, like we could really begin to address low value care. And instead, I think we went the opposite. That people began to say, we got to get volume up because we're losing our shirt.
So Dan, if I heard you right, it's about the evidence base, and I'll separate the next one, taking cost into consideration. So it sounds like you need the clinical evidence, the clinical and epidemiological evidence for one. And as you pointed out, that can deteriorate over time. So you got to establish that and keep it up to date. Taking cost into consideration, and Louis Jacques, he clicked on as soon as I said it. Louis, I'm putting you on notice for cost into consideration, but I'll come back to you soon. The third main one was financial incentives to do the right thing. You said a third of the providers do the right thing anyway, a third will follow, but the last third are the toughest nuts to crack. And then medical education. So did I hear you right then, Dan?
Well, we're still going, but Cliff, yeah.
Oh, good. Oh, I thought you had, so I got five for you now.
That's a good list.
Okay. Did you want to add a sixth? Because I got you,
Well,
I got you five right there.
To appease potentially, and maybe it is a legitimate, is probably malpractice reform.
Oh. You think that will have a significant practical effect,
I'm not sure. When there's been malpractice reform, it's not had a huge impact on low value care.
But if you don't do it, people will point to it as the reason why they want to stick with low value care, probably. So
we need safe harbors.
Got it. I'll give you that as a sixth, the safe harbor. So Louis Jacques, when I heard taking cost into consideration, you came into mind immediately. What can you tell us about that?
Okay, basically, with the exception of screening and prevention, where Congress has authorized the secretary to look at cost or cost effectiveness, it's essentially a third rail for Medicare. But one of the things that's somewhat interesting has been the Inflation Reduction Act essentially repricing of top 10 drugs. Yeah. And it really was sort of surprising to me that the politicals actually went that far, because I think many of us on the Zoom would argue it's long overdue. And that is one aspect of getting at low value healthcare. If you pay less for it, then arguably it's not quite so egregiously low value. But when you think of the amount of litigation that's been done just over 10 drugs, it gives you a preview of what would happen if you went to, even more broadly. In some cases, these drugs have other drugs that'll do the same thing. For example, some of the anticoagulants, things along those lines. So it's just sort of interesting to see. That's the other way to get at low value healthcare, is just simply to drive the cost down. Keep doing everything, but assign it a dollar value of like $2. So it's not non-covered. You're just paying less for it.
Got it. Louis, one more thing. As long as the Medicare statute refers to reasonable and necessary, will reasonable ever be interpreted to embrace costs? Or have we fought that battle and lost?
There was some federal case law tangential to that, and I'm not a healthcare lawyer, but it was essentially around least costly alternative. You may remember in the early aughts, the Office of the Inspector General looked at GnRH or LHRH analogs for prostate cancer, Lupron, Zoladex, Trelstar, et cetera, and said, look, these are all the same thing. Look at any guideline, you use them interchangeably. You should say, use whichever one you want, but we're going to pay you at the lowest price. And that's sort of a regressionary spiral in terms of cost. Someone eventually sued, not over that, but over an inhalation drug where a company took two generics. It was like albuterol and atropine, threw them together, gave it a new name, so priced it at something like 20 times the cost of the individuals. And the MAC said, we'll pay for it, but we'll pay for it at the cost of generic atropine and generic albuterol. The whole thing went to court. And the judge basically said, if Congress has told the secretary how to pay for drugs, the secretary doesn't get to do something else with that pricing. You pay the price that the formula tells you to pay. Now, there was a little conversation in that opinion, and it's been years since I've read it, that basically left open the door that the secretary could say that something was unreasonable because of cost and non-covered entirely. But that's a political third rail.
Still.
Yeah.
Okay, well, thanks, Louis. Wanted to have you weigh in that. I'm going to go to Fenric, and then really interested in hearing what Scott Weingarten has to say after Mark. Go ahead, Mark.
Daniel, first of all, thank you very much. And I'm nervous that I'm going before Scott. He's a giant in this field, but I have a few things to say. First, Louis, the low value care task force deals with things that we wouldn't buy even if they were free. So I suggest that we leave drug price negotiation, which is not at all, as you know, not value driven at all, but entirely volume driven, is not relevant to this conversation. So I would say that you probably agree that they may be overpriced, but they're not low value unless you're going to get into some serious cost effectiveness thing. Section is John Maffei and one of his fellows at the time responded to a request from the Speaker of the House at the time to quantify the amount of money spent on the U.S. Preventive Services Task Force D-rated services. So remember, the task force is the organization that tells us things are so good they must be free. This is under siege, as Cliff mentioned in the Braidwood v. Bashara case, but at least now there's 90 services that must be free. This same organization says you shouldn't do those things. They overlap with the Choosing Wisely recommendations. They overlap with this task force top 5 recommendations. And John's fellow showed that without any cascades, this is $5 billion over 10 years without any cascade. So there's certainly real money there. And since I think Dr. Amorosa is still on the phone and whatever else, one of the things that we've said at this task force meeting is that if you can't start with not paying for things that an organization says are dangerous to do, and while it's recommended in the ACA as a may not pay for D-rated services, not a shall not pay for D-rated services, the last John Maffei and I looked, there's not a payer in this country that's had the courage to say we won't pay for these things, which there's only 6 or 7 that are making things. So we are, as we transition from Daniel Wolfson to the end stage, we've had these services that everyone knows that we shouldn't be doing for decades, and we still continue to buy them. And I have to start listening to Chernu to say, let people order PSAs over 70, let them get mammograms over 75, as in this week's Annals of Internal Medicine, but just figure out, you payers out there, if we cannot pay for these things, what are we going to do? Last thing,
yes,
when we're Scott, Dan, are you finally get on board that we could start paying doctors not to do things? You know,
I've always been on board. I mean,
yes.
Those are my roots.
Those are your roots pre when you started to carry around that ABIMF logo thing on your thing. But the bottom line is as Scott knows, if we start paying cardiologists not to put in stents, if we pay orthopods not to do knee arthroscopies, if we go down that list, I think everyone would be whole, or at least more whole than they are now. Cliff, thank you for the time.
Well, thank you, Mark. And Dan, you don't yet have your last word. I'm going to give you a last word, so keep that in mind.
I'm so glad that Scott is in the meeting. I didn't see him before, but he has done more to implement Choosing Wisely than anybody in the country. So I'm glad.
Okay, just want to tee up a few people. Carol Huffman, you're still on from Emblem. I'd really be interested in hearing your take on what Dan has stated and put out there and some reactions. So Carol, if you don't mind, tee up. Same thing with Amoroso. Tom, I think your light came on at a certain point. You may want to react. Scott Weingarten, remind people of your affiliation.
Good question. I'm still associated with Cedars-Sinai. I'm on a whole bunch of boards, so I don't want to bore people with that. But Daniel, first I want to applaud your leadership. It's been tremendous in healthcare, and you are truly one of my healthcare heroes. So just the contribution you've made to healthcare and to all of us in the United States is going to leave me speechless. But
Back at you.
The way that I look at it, you built, I have a great exercise bicycle in my house. And I know that if I use it, religiously, I will become very fit, and it's up to me to use it. So you've given us all the tools. But let me just tell you about one project that I'm involved in, a company I'm on the board of. And it's not, I think it's really interesting work. It's not being done as rigorously as anybody would like. I don't know if we're going to be able to conclude anything from it. But it's a provider enablement company that works with CMS, Medicare, with both MSSP and the ACO REACH program. And it contracts with independent physicians and takes full risk. So single practice or single doctor practices. But one of the things that it's doing is giving direct rewards for providers for each action, which is high value care, very high value care, such as, patients with heart failure. If there's a medication with a reasonable number needed to treat, that'll prevent hospitalization or death. It'll give the physician, I can't remember the amount, something like $20 every time they either do it or say, I'd like to give Mr. Smith, whatever, a beta blocker for his heart failure, but here are the reasons why I can't do it. So directly rewards. It gets around one of the criticisms that you can do things in an ACO, but if your colleagues don't do all the right things, you get no shared savings. So it rewards directly for your behavior. And then also it's starting to do this with low value care, that, for each low value care item, again, not, each one, I can not do this in the future. It will reward, basically you get a check for each one, or you give a good reason why you should continue with this low value care. I don't know what the reason would be. So it'll be interesting to see. They just kicked it off and hope to have some data, albeit not as scientific as any of us would like, and see whether your hypothesis around incentives dramatically increases the adoption rate.
Scott, just to restate it, say one more time, who is doing this and what might we see it?
Yeah, it's, again, I don't want to overstate this because
let us know.
It's a provider enablement company called Vitalize, VYTALIZE.
Mm-hmm.
It works with a very large number of independent providers.
Mm-hmm.
And it's measuring. So right now there are providers, physicians, and it's going on as we speak. A very small number is part of a pilot initially, who will get checks each time they do the high value care, the very high impact, or they're right now they only have a few low value care items. They're going to expand that based on the great work Daniel has done. And they will get checks if they discontinue low value care or give a really good reason why they need to continue it. And so that's going on. The first providers have been enrolled. It's not being done as part of a study. So, there aren't control groups or things that all of us would like. They're not doing it for that reason. But I think this provider enablement company is going to learn a lot, at least about the use of incentives as it relates to low value care.
Okay, hadn't heard of Vitalize, but now we've heard of it. And I know they did look at choosing wisely. We want to make sure, by the way, they've seen what this task force has cranked out insofar as low value services. I know there's overlap, but it may strengthen their position. I saw that Carol had to just step away, so I'm going to jump to Tom, and then we may go back to Beth. Although Beth, I want you to kind of kick off our next session. So Tom, reactions. Tom Amoroso.
Excuse me. Well, I'm really just going to pick on one, and there's a reason I'm picking on this one. There's a perception that a health insurance organization has data that is sufficiently granular that we can sort of sort out the people who are doing PSAs for prostate cancer screening from the people who are doing PSAs for other good and valid reasons, like following an actual prostate cancer, for example. We don't. What we can do, and what we have done, or what my organization has done, is look at the universe, because there's a huge universe of PSA related screening tests. All of them are non-covered. because we have this whole long, really long list of non-covered investigational services, and anything that has no value gets slapped onto the list because it has no value. But it's difficult to do that for things which have value only in certain circumstances. Not impossible, but it's difficult. And as we get more granular data, it may become possible. Someone in the chat points out that his opinion that norms are more important than incentives. Okay, so I actually think both norms and incentives are critical. I'm a big fan of norms, frankly, mostly because I did my Master's in Public Health project. But moving along, in creating and enforcing norms is both difficult and culturally and financially usually expensive, because you have to create the norms and then you have to do what I called academic detailing to promote and enforce them, and it takes time and it's not free. So incentives may be faster and cheaper. I'm not sure. I don't know.
Incentives may help normalize,
Also
certainly.
true.
Mark, I want to make sure we give Dan a last word on this segment. So if you want to say something before Dan's last word, please do so now.
I do, and this segment's going to roll in as you.
Be smooth.
Your amazing agenda, but
going to Beth next.
Because Dr. Amoroso is now my new best friend, I'm going to call him Tom. And so Tom, we're happy to send you the 14 recordings of the task force. So it's important just for me to remind everyone that the whole VBID movement, high and low value care, is based on this idea of clinical nuance, meaning that no service is ever high or low value. But what we have done, Tom, is create something called a waste index, which will help you, if you'd like, to identify those services that when they're performed, they're almost always performed in a low value care setting. So as Cliff knows, as he almost has an honorary MD, vitamin D testing has been the flagship low value care service because no one makes money on it. No doctor really cares about it. And I'm not sure what your health plan does, but Louis Jacques knows, and the Aetna folks and the Cigna folks know that they don't no longer cover vitamin D screening in average risk people.
Neither do we.
Or we know you do or you don't. So what I'm saying is it's hard, but it can be done. And if we grow, whatever direction you want to grow, we are happy to work with you to find ways to grow on choosing wisely. Vitamin D testing, PSA over 7, things that are easier as opposed to harder to identify a non-payment decision.
Thanks very much, Mark. Before we move to our next sort of segment, wanted to bounce it back to Dan Wolfson. And of course, thanking you once again, Dan, because that was a very valuable sort of benchmark historically and currently for understanding this. And you set us off very nicely with a half a dozen kind of have-to-dos for the next phase. Final comments and reactions, Dan.
So I'm going to go reflect back on Beth's presentation. Whatever we do, I think we need to align with professional values and intrinsic motivation. And Beth's, kind of getting feedback and beginning to have conversations is an excellent example of trying to take the best out of the profession with intrinsic motivation as its driver. And I think that was what Choosing Wisely was trying to go after. How can we get the profession through intrinsic motivation to do the right thing? So if we can develop interventions, incentives that call on the best of physicians, I think that's what Choosing Wisely was trying to do, and to continue a conversation with doctors about their responsibilities and patients about their responsibilities as well in this. It was great. Thank you very much for having me. I'm always impressed by if I'm ever in a bad mood, I should call Mark and let him give me the ridiculous accolades he gives me, and the overtop hyperbolic accolades. So thank you so much, all. You're a great group. I hope to continue participation with you over the years and continue to learn a lot from all of you.
Thank you very much, Dan. And stick around in any way you so choose. This ain't no curtain call for you. People are going to need you for this stuff. Thank you.
Thank you.
Okay. We're going to move into priorities moving forward for the task force on low value care. A couple things. One, and I'm going to go, if she doesn't mind, to Beth Bortz first to kick us off on this. And again, it's kind of a nice transition from our previous discussion. But in addition, I saw Katie Spangler on, I saw Beth Bodan-Seiler on, and a few others from whom we haven't heard, I don't think just yet. And so I'd really like to, given the size of our group, to have sort of a more intimate conversation where we're all involved. And so if you haven't spoken up and you're saving up something great, we'd love to hear it. I think Robin Kahn was on my list too, a few other folks. So Beth, taking it forward with a set of next priorities and maybe kind of building off of what Dan said. I took my notes. He had six good kind of takeaways from that. Where do you want to go next, Beth?
So I have three points, Cliff, that I have written down, that two which are a little bit of follow-up to Dan's presentation, and then the third is just a next generation thing. So my first response, and I should identify myself in this part as a former patient member of the American Board of Family Medicine.
Okay.
And I say that because I think that in a profession that is self-regulated, as the physician profession is by groups like Dan's, I think that patients would find it somewhat repulsive to talk about incentivizing physicians to do the wrong thing. I mean, to not do the wrong thing. I mean, I don't have to incentivize my car mechanic not to slash my tires, right? I mean, I'm just saying patients would not take kindly if they were to discover that that's how we are operating. So, also, I will say that Howard Beckman's research and the, that we employed was that physicians actually find financial incentives repulsive. I mean, they want to do the right thing. That is the messaging that has worked far more effectively than talking to them about changes in payment. Now that's the frontline clinician. There may be organizational incentives that are different, but when you actually talk about the person that tends to be ordering the test or procedure, they want to do the right thing. And I think data, if you give them good data that they can use to help them figure out what the right thing is, I think that's how you will make real change. So that's just my first response.
Okay.
My second piece is that I think the challenge that we have, and I think, Dan did some really amazing out of the box work in the early days with Choosing Wisely and leading it from ABIM. I think the challenge that I see is that it was always going to be hard for a member association to lead this work. Because at the end of the day, ABIM is a membership organization, and you can only hold your members so accountable. Dan, I thought, made an excellent point, which was some of the societies did a really good job identifying 5 tests or procedures. Some really did not. Some didn't offer up things that would have led to meaningful change. And I think that was purposeful. So again, I'm not sure that ultimately you can ask, a group that financially benefits from the pen and ordering things to do this purely by self-regulation through their membership organization. And I think the hard place where we are now is that when ABIM shifted their priorities to trust, which again, great visionary and necessary piece, there's not really a transition plan in place. There was no sustainability, what's next, who's taking over this work. And that has left those of us in the field a little bit in the lurch. There aren't updated lists coming out. We don't, where is this work happening? So my third piece is that where I see it happening now is in the private sector. There are initiatives such as Practicing Wisely, the Global Appropriateness Measures, Care Journey. These are all tools, technology tools that employers can purchase or have, agents on their behalf use for them to do analysis of their employer base. But the problem is, and I pointed this out earlier when Mike Chernew was talking, that all of those are proprietary, just like the health waste calculator is proprietary. And so when you look at doing a statewide initiative like we've tried to do, the problem is different entities, even if they want to get in the game, they would have to purchase a proprietary tool to kind of get information. And that becomes a very hard bar, to initial entry into the game, if you will, that they're going to have to purchase one of these tools, or they've purchased different tools and now they don't get the same results. And so I think that's another challenge that we need to think about. How do we get data shared across different entities in a way that everybody kind of agrees on the data?
So if I heard you right then, Beth, made three main points. One is that patients aren't going to go easy on any sort of system that pays docs to not do the wrong thing. Like that's not going to play well politically. And you're saying that providers generally do want to do the right thing. And I'm assuming that that observation comes from your experience in Virginia, for example, in your interactions and what's worked and what hasn't. So point well taken. You point out that insofar as, I guess I'll rephrase, ABIM Foundation did a good thing and the right thing for years, but you do observe that it's hard for a provider member association to carry this ball forward. And that, in fact, when ABIM Foundation had to kind of shut this down, there wasn't a transition plan, which kind of leaves folks in lurch, because you kind of want a live body still turning the crank on these things, updating the evidence and kind of adding and modifying the list. Point well taken. And then your third main point is that, well, there are some private sector proprietary groups out there kind of generating tools and so forth to analyze their employer base and other data and so forth, but that may not be desirable insofar as the proprietary nature of it. And you'd really want something more in the public sector or the public domain that we can all share and that we actually might increase the leverage. So your 3 points are outstanding, well taken, and I will go in order to Chernew and Weingarten next. Mike Chernew.
So I agree with Beth. I'll say just a few related things. We actually published Aaron Schwartz's code that was actually free to be able to measure low value care, but actually being able to use it and update it. It was ICD-9. There were changes in the literature, turned out to be really expensive. That's actually how we ended up working with Milliman as an aside. And the key thing about Milliman is their tool is proprietary, that part's true, but it's actually unbelievably cheap relative to the actual amount of low value care that it measures. And I can't remember anyway, that's the tool that you use, Beth, so you know the waste calculator well. And in fact, I think one of the ways that this could all work out, back to my original point about holding the carriers responsible, is the carriers could purchase the tool. It would cost them some money, but much less than the amount of low value care. They could do all the profiling and all the support they wanted if they were actually held accountable for getting rid of the low value care. But the carriers aren't held accountable for getting rid of the low value care. So their incentive to invest, I think you have to get rid of like less than 1% of the measured low value care to have the tool pay for itself. And if you got rid of 1%, you'd like 10 times your money. Some version of that and how it's priced. But the issue about measurement is it is actually quite complicated to build the tools and maintain the tools. And so you're better off having people incented to get rid of low value care. They will be forced to invest what I consider to be a quite small amount in the tool in order to then get rid of care. And then you could have it documented, and the waste calculator could surely be better. Beth, you can talk about your experience. It currently worked to support what they were doing in Virginia. You could come up with other tools. It doesn't matter. I do think it's useful to have a third party kind of tool. And I think it's valuable if it's very cheap, even if it's proprietary. And I think the question is who's going to pay. It is hard to get the delivery systems to pay because then you're paying them to figure out how to get rid of care that is also not going to help them financially. But I think the carriers and others, and the states, by the way, we did a lot of work with the states, really have an incentive to do this measurement to support this activity. And it's just that the purchasers, in my opinion, have to force them to do it or incent them to do it.
So Cherna was positing that these tools definitely are good ROI, and that could cascade into further savings. Mike, would they be better though to have just one kind of nationally recognized standard tool, as opposed to having a bunch out there, or do you think that doesn't matter much?
I think if I could snap my fingers of it, a nationally recognized tool that you could use and then you could adopt very easily, I think sure. The problem is having the resources to maintain that and go through the system and the process of how you're going to build it, how you're going to make the decisions, what you're going to do, how you're going to implement it. You know, the Milliman tool, and so I've learned more about this. How you implement it in Virginia is going to be different than we were trying to implement this in Colorado, Oregon, Washington State, Utah, a bunch of places, Massachusetts, and there's just HCCI. There's just a ton of healthcare data just in general is really messy and really hard to deal with things. I don't think that the notion of just having a national tool and saying, okay, we're going to use it is going to remotely get us where we need, because you need some organization to be able to do all the implementation, to be able to update it. You need to have it be able to be developed without having all of the problems that occur at a national level, as we just had about we had a whole chat about the inpatient only list and why it couldn't get done. So if the question is theoretically, is the ideal a publicly available national tool that could be implemented with a bunch of unbelievably disparate IT systems? Sure. If the question is we actually want to do something, I think you're much better off getting a very cheap tool that someone has some money to pay and invest in and just get it done. And you could do that a lot easier than trying to get a national tool.
Fair enough. Point well taken. Wanted to raise it. We're going to go to Weingarten next, followed by David Kim. Scott.
Yeah, I think a lot of really good comments, a lot of very important comments. You know, one thing that I question, there's been a lot of work to reduce low value care over decades now. Great work. Choosing Wisely, outstanding. A lot of other work, even before Choosing Wisely. I'm not aware of any evidence that low value care has significantly declined despite all of the great work that has gone on. And please, we have all the experts here. If there is, evidence that low value care has declined over the last 10, 20, 30 years, please let me know, but I haven't read that. So clearly what we're doing today in a fee-for-service environment, if that's correct, isn't working. And so I think we need to do something differently. And so I think incentives are important. I think it's hard. It's like pushing a rock uphill in a fee-for-service environment. When I go to the barber for a haircut, my barber has never said to me, Scott, your hair looks just fine. You don't need a haircut. Never happened. I'm still waiting for that. He makes money every time I get my haircut. When I go to the local ice cream store, no one ever, the person who serves me doesn't say, what is my cholesterol? I'm not sure you should be eating ice cream, Mr. Weingarten, Dr. Weingarten, whatever it might be. So I do believe that incentives are important. I do agree that providers, physicians want to do the right thing. They've wanted to do the right thing for hundreds of years, probably certainly over the last few decades, but wanting to do the right thing alone, I don't think has moved the needle in the direction we would want.
So Scott, the first step you'd want to take for a financial incentive to do the right thing is what?
The first thing, I actually think that by providers engaging with the evidence, I believe in what, Vitalize is doing. Providers, even though it would be, I completely agree, very challenging to explain to patients. I get that and I appreciate it and agree with that. But providers engaging with the evidence and saying, I'm going to do this, or I'm going to stop this low value care, or I'm going to continue it because I think it's in the best interest of my patients, but having that discussion and rewarding them for their time, for participating in that discussion, I think could yield better results than what we've achieved in the past.
Okay, pay them to participate in the discussion, but pay them or not pay them for what they do in practice?
No, as long as they participate and say, I'm not going to do this low value care because it's not in the best interest, or I need to do it because I really believe for the following reasons, but despite the evidence, I think it's helpful, but getting them involved on a patient by patient basis. We'll see. I think there are other ways of incenting providers. I'm just saying, my belief is what we've done to date, despite fabulous work by people on this call and people not on this call, just hasn't been as successful as any of us would have liked. And that's why VBID will continue for the foreseeable future.
Points well taken. Thank you very much, Scott. Let's go to David Kim next, and we'll go to Beth after David and then back to Dan. David.
Yeah, this is David Kim, and then I'm a researcher who's kind of quantifying low value care. And then our team's currently doing more researches on the quantifying cascade care. So I'd just like to give a brief update that we look at the Medicare populations and then what are the consequences of three low value cancer screenings, prostate cancer screenings, cervical cancer, and colorectal cancer screening. And what we are finding is that there are about $500 million wasteful spending associated with the initial three low value cancer screening. But also, if you're thinking about like all the cascaded care associated with the additional screening test, diagnosis test, and then a follow-up treatment procedures, we also got, kind of multipliers of the two. So we got like 1 billion the additional wasteful spending. So what we are quantifying is that there are about like 1.5 billion wasteful spending associated with just three low-value cancer screening, most commonly done in this Medicare population. Whether it's large or small, there are like great discussions we already have it. But the way I think about it is that $1.5 billion will provide it access to anti-obesity medications, which have a hot topic, and then people discussing a lot about affordability issues. But we can provide it like 150,000 individual additional access to the anti-obesity medications that has been shown to be pretty effective. So these are kind of line of the work that I continue to generate more evidence. And then we also looking at the adverse consequences of these low value services. So not just looking at what we are doing or the how much we spend, but we also look at more impact on the hospital acquired conditions, patient safety indicator, and unplanned hospital admission, so that not just on the cost side, but also it kind of showed that it has some detrimental effects on the patients, the quality of care. So just give you some updates, and then I'll give some updates on the Academy Health as well. So
please do. And by the way, Dave, just you help to exemplify. By the way, tell folks you're a researcher with what institution?
Oh yeah, sorry. Yeah, I'm a faculty at University of Chicago. Sorry.
Right, University of Chicago. So what you are exemplifying is that we need to, on an ongoing basis, keep generating this evidence, clinical and economic along the way, macro and microeconomic effects and so forth. So there needs to be this research engine ongoing to continue to feed this. Thank you. Beth, thank you. Beth Butt-Sauer, remind folks about your affiliation, Beth.
So I am with Altarum in the Applied Research and Analytics Division, and Mark and I have done some research on the low value care stuff. And great conversation. I think that, our research, when we looked at it, showed that some of the low value care stuff really fell into three different buckets. It can be patient driven, although I agree completely with Daniel. I don't think that there's a lot of patients and others on this call that said, I don't think that it's patient driven a lot. Or that there are a lot of low value care services that are patient driven, provider driven, and then system driven, right? I think that to focus on just any one of these by saying educating patients is what's going to fix a lot of things probably isn't true. Just to push just on providers and to say that, well, if we educate providers more, or we incentivize providers just in that, probably isn't is going to move the needle a little farther, but probably not all the way. But by a combination of all three, where we educate patients on what they need and what they don't need, where we educate providers on what should be done and what shouldn't be done, and help them with the guidelines and incentivize them in the right way, and then incentivize the systems themselves to reduce low value care and provide high value care, in terms of like the electronic systems where, yeah, we may need to put some reminders in and generate in the electronic systems what reminders are, but what the guidelines are, and do you really want to do this kind of pushes and nudges and things like that, I think could help too. But I think it's like a three-pronged approach, really.
Well, Beth, thank you. Educating patients, educating providers, incentivizing the system. And I'm so glad you raised the EHR, because the nudges thing may be really key here. I mean, if just sometimes it's just kind of putting that light on again, that reminder is something that can kind of call attention to the docs. And by the way, make them more accountable. It's not like we didn't remind you that at this point, that's not the test we're looking for. Thank you very much, Beth. Dan, back to you.
Maybe Scott can enlighten us about how alerts have worked or not. I just want to say to Beth, I'm sorry. I apologize. Two, I love
No
you.
regrets on this call. No regrets.
Dan, you did great work. That's what I started with.
Heck yeah.
I'm not
Okay,
there anymore
but-
doing it.
The foundation is not a base to do it in. And, Peterson's not going to fund you forever. Stop funding you. We got to find an economic model to fund the infrastructure. And we're not going to do it unless we can generate savings and pay people for this to share in some of those savings. They're just not going to do it. And so if you were to tell the public and the physicians, we're doing this because it will support the infrastructure that is needed to decrease unnecessary care. It's not going to happen by itself. I don't think it's going to happen all by a conversation. I think it needs systems, reinforcement, a battery of things to move the needle. It's not one thing. And we need to get multiple kinds of interventions. We know from quality improvement techniques that, one intervention doesn't work, 4 probably do, and we'll never figure out which is the most important one out of the 4, but that's just how quality improvement goes. So.
Excellent. Thank you, Dan. Thank you for that. John Maffey, I just made a note to myself, call on Maffey. So are you going to reflect on the kind of the cascade thing here? The dropping the pre-ops? Please weigh in, John.
Oh, sure. Thank you for the kind words, Cliff, and you're doing an amazing job. And thanks everyone for all the comments. And I just wanted to add to the conversation that, yeah, we've studied trends in low value care across the entire Medicare fee-for-service program and found very little change over time, despite the dissemination of Choosing Wisely and many other guidelines over many decades. And so I just want to, add to that there has been very little progress with guidelines alone, and this is not a surprising finding. And I think ABIM knew that, and that's exactly why ABIM began to pilot innovation grants across the country. And we were a recipient of this at LA County, where we were able to reduce preoperative testing by 70–80%, absolute reductions. And this was catalyzed by an ABIMF Choosing Wisely grant, because they understood that you can't just expect people to change behavior with guidelines alone. You need a catalyst. But the other piece to this is that one of the main reasons that there hasn't been a big decline in overuse is in low value care is that the predominant chassis of American financial reimbursement system is still fee for service, as everyone has been saying. And these sort of risk-based or value-based contracting models are very rare relative to the fee-for-service paradigm. And so with that financial piece in place, it's very hard to get health systems to start to reduce unnecessary care. There can be some small wins in areas where there's access to care barriers, And you could say, well, if we reduce low value specialty referrals or other things, you can make room, or low value colonoscopies, you can make room for high value care, but it's piecemeal. And so you need the financial piece in place, and ideally in a capitated environment. But the other point I want to make is that even when you have all the financial and economic pieces in the right setting, you still have very high rates of low value care.
Yeah.
Have high rates of low value care in England's capitated NHS system. You have high rates of low value care in the Veterans Administration, which is a capitated system. And here in LA, we found like 90% of patients were getting preoperative testing for cataract surgery, even in prior to our intervention.
Oh.
And so you need the finances, you need the education, but you need that third thing. And that's really about this paper that Howard Beckman wrote, that Beth and I were co-authors on, this sort of 10-step program to reduce low value care, which I put in the chat, which is all about respectful discussion and non-judgmental conversation around data and variation in overuse, and really about giving the physicians autonomy to decide for themselves how they want to write their own local guidelines. And then with the financial backing, you need to have the finances there first and then have the conversation. And that's exactly what we saw happen in LA County, which is what led to, you had the education, you had the financial model in place. It was a mostly capitated model. And then you had this physician engagement with data-driven, non-judgmental conversation, rewriting the guidelines. Those three things led to the 70–80% reduction in over. So it is achievable. It is achievable. You just need to have all the ingredients in place. Money is necessary, but insufficient.
John, one thing I just wanted to check on, because we haven't heard a lot about guidelines today. Can you please clarify how we get to the guidelines and influence them? We take things in order and then say, okay, everybody, here's the evidence. We may or may not have financial incentives in place, but you need to build this into your guideline. Is that a tough bridge, river to cross?
Yeah, it can be. It's very fraught, because when you're talking with doctors about their care patterns, it can get very fraught. And Howard Beckman has had over 20 years of experience working with doctors on this. And that's what Steve was talking about, the table metaphor. And I found myself on the wrong side of the table myself, trying to talk to doctors about their care patterns. And you need to read the paper to see how you can avoid these difficult conversations. Ultimately, for instance, like in the article, often when you show doctors their own variation data, they get upset, they get angry naturally.
Yeah.
And so, instead of ignoring it and trying to talk over it, Howard's recommendation is, based on human psychology research, is to just call it out in the elephant in the room. You seem angry. And eventually, the doctor will say, yeah, I'm angry. And well, tell me what you're angry about. And the doctor will say, well, I think these data you're showing us are invalid. I don't believe it. And they're really crappy data. And then your response can be, well, I'd love to work with you and partner with you on delving into this data to make it better and more meaningful for everyone. Do you want to partner with me to do that? And so he has these sort of choice phrases to help you sort of navigate a conversation that could go really disastrous into something that could be a win-win. So encourage you.
That's great. John, very helpful. Now, I am going to go to Fendrick to get kind of a semi-last word on this segment. But Jeff Levin Schertz, if you don't mind, I would request that you verbalize briefly the concluding points that you had drawn. Jeff?
All right. Well, thanks. Well, first of all, thanks tons to the Center for Value-Based Insurance Design. This was an amazing session. Not surprising, they always are, but I think this was really helpful. So my conclusion, the first is that guidelines aren't enough, but they really are foundational. We're just not going to make any progress without them. And I do feel like the PIM Foundation, I appreciate Dan's leadership, did a lot of really good stuff, but the fact that it's all sort of gone to the wind is a big loss. The second is incentives to organized systems seem like a really good idea, but incentives to individual doctors are really deeply problematic. And the third is just the conversation here makes it clear there are so many good people working on this, and we have to be patient, but I feel hopeful. So thanks. Those were my thoughts.
Thank you very much, Jeff. Mark, before we turn to Mike Chernew for his view on next steps and some wisdom prior to adjournment. Mark, I wonder if you could bridge this conversation that we just had into what you see as next steps for the task force. Mark?
Exactly what I want to do. So thank you, Cliff, and I'm thanking you now formally. Just amazing. 15 times, you've never missed one, and we can't wait to see you on October 1st. I'm going to say a couple things. One about guidelines. Just remember what I keep saying, what we wrote, Mike and I and Dean Smith, in our very first low value care paper, is that the task force D-rated services, Cliff, if you could take down the slide, please,
Yeah.
Susan.
Previous, yeah.
The D-rated services are where we could start. And I turn to my new best friend, Tom Amoroso, and others in this regard. So we've kind of got the guideline starting point. We could also build on that. Second is, I wish I could have the slide down so I could see my friend, Dan Wolfson. So we've waited 15 meetings to get the godfather of low value.
Mark, just a minute. Susan Lynn, can you just go back to the slide, to the pictures of everyone rather than this slide? Not quite there yet.
We take the slides down, please.
Yeah, if you don't mind. Thank you very much. Mark, sorry to interrupt. Back to you.
But I just, because I can't, now that I could see the godfather.
Right.
So Daniel, thank you very much for kind of setting, this has been very important for us as we kind of tee up the next 15 meetings, if Cliff is willing to do them. And I put in the chat, I just want to spend 1 minute about choosing wisely, because Dan and the organization took a lot of criticism, including a New England Journal paper that may or may not have been started, the death knell, to which many of us who strongly supported Dan and the program wrote in the New England Journal of Medicine that even though Scott Weingarten and John Moffey are going to tell us we haven't reduced low value care to the levels that many people wanted, what they left behind in terms of tools that we talked about, implementations that I put in the chat, a very serious systematic review by our student, now Dave Kim's colleague at University of Chicago, Betsy Cliff. We have funding sources now for people who are, in addition to choosing wisely, the Arnold Foundation, Arnold Ventures giving out money to allow this to be moved forward. And what I'm so proud of is I look at John Moffey's picture, a cohort of young investigators at Cliff. You've moderated over 15 meetings, just one after another, doing amazing work. David, Kim, and John, thank you so much for all you've done in this space. And of course, the education piece, which I'm going to leave with a little philosophical point, as some of you might know, it is now the Passover holiday. And if you've seen the 10 Commandments, or if you know anything about Passover, you know it's the story about the Jewish people leaving slavery in Egypt and crossing the Red Sea. But what many people don't know is that every slave that crossed the Red Sea was not allowed to go into the Promised Land. The Jews wandered in the desert for 40 years, such that everyone who was in Egypt actually died. And why I bring that up, to John Moffey's point, is those of us, Tom, Jeff Levin-Schertz, the other clinicians on this call, who grew up in fee-for-service, we must die. We all must die before someone like John Moffey and David Kim could lead us into the Promised Land and actually do what we were supposed to do when we trained to be clinicians, is put patients first, and as Beth put in the chat, follow Hippocrates' oath that we all take in first do no harm. And what this task force is about, as I turn it over to you, Mike, is we're going to continue to fight to, one, do no harm. And second, hopefully if we're lucky enough, take some of those dollars that John and David and others, Ashani, have been able to show, and spend them on the things for our patients who need them so desperately, who can't get them because of the way that our system works. So Cliff, thank you. Members, thank you. See you October 1st. Susan, Lynn, and Jordan, thank you. Mike, I'll turn it over to you to close it out.
So I'm going to close it out very quickly. First, let me thank Jordan and Susan Lynn for once again doing a spectacular job. Cliff, you have my thanks as well. Again, 15 and counting, could not be better. And obviously, thanks to Mark for really putting the entire thing together, particularly the agenda. And so Mark gets credit for the agenda, which I thought was outstanding, and the sort of attendees. I really enjoy this meeting. It's the right size. It's small enough that people can comment. The chat's been wonderful. and it's big enough that you get a lot of diversity of views. What I took from this, and thanks to Silas and J&J for their support, we couldn't do it without them. But what I took from this broadly is this connection between two things. The first one is we started off with Beth and Emblem, Smarter Care Virginia and Emblem on things they're doing. There's a lot of work on people that are doing things that remains important. But so much of today has been about the incentives and how the incentives flow and what level the incentives go at and who's going to keep the savings when the low value care goes away, and that kind of stuff. And I do think going forward, we need to think about the infrastructure to support the removal of low value care and high value care for that matter. And that infrastructure is going to involve incentives, and those incentives are going to be at a higher level. And what I'm increasingly realizing, and the reason why people like Jeff, who I see is still here, are so important is because at the end of the day, the current system is going to require the purchasers to push it to be better. There's only so far we're going to go otherwise. And so some of that's going to be the government, a lot of that's going to be the private sector, because we're not going to be able to sustain the momentum, in my opinion, unless we get the people who will ultimately benefit financially, which, you know, by and large, the employers, the purchasers, and their employees, to really step up and sort of demand we do better. And what was clear is there's so many different things we could do. There's new payment models. There's information incentives like at UVA. There's engaging the delivery systems. There's the, you could do with them prior auth. There's a lot of things that can be done if people want to figure out what we can do. There's not going to be a one-size-fits-all approach. So I think we need to continue to figure out what can actually be done. But I think increasingly more importantly, we have to think about what macro infrastructure we need to get the people to actually take those actions to sustain the Smarter Care. The reason why it's hard to get Smarter Care Virginia to continue in some, or not to continue, but to sort of diffuse beyond Virginia, is because you need to have the groundwork and the people and the energy of Beth going to other places and get those folks on board, and they need incentives to do that. So I think we need to think a little bit more about the macro incentive infrastructure parallel to the micro innovations of what we do, and accept that what they're going to do in California and what they're going to do in Maine and Virginia is just going to be different. But I think it can work in the end. It will pay off. So again, I'm just going to leave in part because I got to go to a different meeting to talk about how to transform American healthcare system. I'm basically going to give the same speech, by the way. But thank you all for attending. It is really an honor to have you join us. And so be safe. October 1st, put it on your calendar, and we will see you all again. But again, thanks.
Thank you, Mike. Thank you, Mike, for your leadership as well. Take care, everybody.
Okay. Bye.
Thanks,
Bye-bye.
everybody. Bye-bye.
Thanks all. Bye-bye.